everybody. We've got an illustrious attendance today from lots of our partners, so thank you everybody for coming, and a pretty big agenda with a special focus on mental health, but with a fair wind. I hope we can keep to time, and we're looking forward to all of your contributions. So I'm going to start the meeting. We have got apologies from Councillor Tracy Coombs and Councillor Lauren Edwards, but we have substitute from Councillor Gareth Myton and Councillor Hazel Brown. So that's welcome. Are there any other apologies? We've also got an apology from Paul Bentley at the ICB, but Vincent, you're here representing the ICB.
Donna Marriott.
Oh, and Donna Marriott now. Yeah. Any other apologies, anybody? Okay, thank you. I'm going to ask you to accept the record of the meeting on the 23rd of November for the purposes of our records. Is that correct? Okay, thank you. I don't think you were here, Jane, were you actually? But no, okay. But, anyway, we're accepting those, so that's good. And are there any urgent matters? I think all the matters on our agenda are urgent today, actually, in one way or another, but we'll work through them together. Any declarations of disclosable pecuniary interests and other significant interests? Hazel?
Yeah, I work for a charity that is a provider in the mental health sphere and has one contract within the area.
For the
Sorry, it's Hestia, Hestia.
Okay.
Thank you.
Are you all right, Eddie? Did you want to?
Yeah, so I feel embarrassed now because I haven't really thought about this. I work in mental health for a company called Sanctuary Supported Living.
Yeah,
So,
I think it's,
yeah.
you know, if in doubt, declare.
Yeah, there you go.
I always say.
Thank you.
I'm not going to do formal introductions because there are so many of us, but can I ask you, when it's your turn to speak, if you do introduce yourself for the first time, so everyone else can pick that up, please. It's lovely to see you all here. And just a reminder, you know, the Health and Wellbeing Board is taking care of the health and wellbeing of people in Medway, and we're thinking about, in all of the items, what can we do together to make things better? How can we keep people safe? How can we improve our services? What's our collective action? So very pleased at the end of any item, for those who haven't been here before, to hear your views on how we can make those things happen. You know, if there's something you think your organisation can be doing with the rest of us, or something that we can all do collectively that we're not doing now, then I'm very pleased to hear those things. And we've got our Vice Chairman, Jane Black, Vice Chairperson, I should say, thank you, Teresa, here from hospital. So I'll be going to Jane to just sign off every item as we go through. Is that all right with everybody? Okay. So our first item then is the GP Practice Development Plan, and I'm pleased to have Sukh Singh and Ash Bashan here to help us introduce it. And as Ash has just said to me, we've got to get on with this. Welcome, Jane. Yeah, no problem. Have a seat. I just want to say a couple of things at the start of this item. In part, I hope, informed by the good work of the task group, and I do thank you both, actually, for the great presentation you gave to our Health and Adult Scrutiny Committee. I think that was extremely insightful and appreciated by lots of people, and not just people at the committee, because I've had quite a lot of feedback online from people who watch. So that was helpful. So this is the strategy for improving GP services. I do want everybody to be mindful of how much pressure the services are under in primary care, how many more people we are seeing. I'm very aware that there's still inconsistency, and I'm sure Sukh and Ash will come to that. But I remind everybody, GP services are fantastic value for money. It costs about £40 to visit a GP compared to about 200 for somebody to go up to A&E. And actually, often the effect is the same. So it's up to all of us, and as partners and as individuals, to remind people to join with our GP services in the improvements they're trying to make in modernisation, asking people to use e-consult, ask people not to always expect that they will see a GP if they go to their GP practice. They may see somebody who is more appropriate for them at that time. And also, again, it's beholden on all of us and all of the residents, particularly as politicians that we represent, to work together to keep themselves well and join in with all of the strategies that we'll hear about in the Public Health Annual Report, to do things that keep ourselves well. And by doing that, we'll help make the strategy work. So if I go over to you, Suk, first, and Ash, to hear about the strategy.
Thank you. So thank you for inviting us this afternoon. Just by way of introduction, so my name is Suk Singh. I'm the Director of Primary Care at the ICB, and we've got Dr. Ash Peshan, who's the Deputy Chief Medical Officer at the NHS Kent and Medway ICB as well with me today. Just some background to the GP development plan. So we've included a presentation, which I'll just talk through quickly because I don't want to give death by PowerPoints, but more open to the conversation around, particularly with the context that you've set, Councillor Murray, in terms of where we are. But back in September of 2022, I came to the Health and Wellbeing Board then and presented the GP development plan. So the purpose of today is to give an update in terms of where we are. And I think kind of what Ash was mentioning is kind of where do we go next? And I think it's just helpful to set the context of our primary care strategy and what we're trying to do to develop that. So, as I mentioned, some background to the GP development plan. Recognising some of the challenges that we experience, the GP development plan was set up to see how we can develop resilient healthcare services within general practice, and also improve the health and well-being of our residents. They were the two key ambitions that we were looking at. And then there were 4 areas that we focused on. One is around the quality, so making sure that we've got good quality services that are available to our population, sustainability of our providers and a thriving general practice and how we can create that, deliver proactive and accessible coordinated care for our population, and recognising that general practice is part of a wider system, is how can we start to integrate services more closely to meet the needs of our population. The next slide, and again, I won't talk through all of these areas, but it just highlighted, I guess, some focused areas that we were looking at. So it was around access, workforce, quality, outcomes, and technology. So how can they all kind of work together to support the ability for our patients to be able to access services and also to support our providers? So one of the things that we know is that there aren't enough GPs. Within Kent and Medway, we have real big challenges around GP recruitment and retention, but there are some things that we have been doing very proactively to try and address that. So we launched our GP attraction package in January of last year, which focused on areas where we had the lowest ratio of GPs to patients, and that was Medway, Swale and Thanet. And throughout this presentation, I'll kind of give a Medway update in terms of where we are on that. So for the GP attraction package, that was an offer which looked at working collaboratively with the council, seeing what we can offer to GPs coming to work within Kent and Medway, and it offered financial, housing and development support for those individuals. So it's not just about recruiting people, but actually how can we get them to really become part of a practice team and set down roots within the area as well. And through that, we've had 3 practices in Medway that have successfully recruited GPs. So the Red Suite in Balmoral Gardens, Courtview and Maritime Health Partnership have all managed to recruit through that programme. And actually Maritime Health Partnership have recruited a couple of GPs as well. So they've made some really good use of that programme. But the one thing I think we all recognise is that GPs are part of the workforce, but there is now a wider workforce that exists within general practice that are also there to support individuals. We have seen some significant increases in the additional roles. So these are additional roles that are now available in general practice. So back in 2022, we had 408 whole-time equivalents. We now have 956 whole-time equivalents working in those roles. So quite a significant increase in the numbers that have been recruited. For Medway specifically, there are 129 whole-time equivalents in those roles, and we've just included at the bottom kind of what those roles cover. So we've got clinical pharmacists, social prescribing link workers, first contact physiotherapists, and a number of other roles that are there to support patients. One of the things that we do need to do, and this might be, I guess, something that we discuss later on, is actually how can we build confidence and trust amongst the public in those additional roles, and also how can we really kind of demonstrate to people what they are there to support. So they can be quite often well placed and better placed to support people's needs depending on what they're presenting with. So I think it's just about building that confidence and trust with the public in those additional roles that we've got. Another area which we've seen some really good progress on is our Tier 2 visa programme. So we have a number of multi-professionals and GPs who are working in the UK on a skilled worker visa. And we've managed to get our practices to start to, through their application process, and we've got 15 practices in Medway who hold a licence, and 6 practices are successfully recruited through this programme as well. And again, we've just listed some of those practices at the bottom, so you can see Reach, Phoenix and Maritime Health have been really successful in recruiting through that. So again, it's looking at all the opportunities that we've got to be able to increase the workforce that we've got within primary care. One of the things that I wanted to highlight, I guess, was GP workforce trends. I wanted to include it in the pack just to show where we've come. So back in 2017 to 2020, there was a decline in GP numbers that we've seen across Kent and Medway, and specifically within Medway. On a positive note, is that since then, that dip in 2020, each year there has been an increase in the total number of GPs in Medway. So the trajectory is going in the right direction. So again, I think it's important to recognise that whilst we recognise the value of the wider workforce, we also want to make sure that we do have an appropriate number of GPs, and a lot of these initiatives that we're working through are helping to address some of those challenges. We have got some more context about the GP attraction programme. I won't go into too much detail. I think I've covered most of these a moment ago. But again, it's just really highlighting about how this package, this programme of support and offer is really important for encouraging people to want to stay and work in general practice within Medway. And also, I guess, how we make sure that we help their ongoing learning and development through this programme as well. I mentioned a lot about attracting new people in, but it's also, there is a lot of work around retention, and there are a number of initiatives that we all offer across to primary care around recruitment and retention initiatives. So there's fellowships, educator roles, there's mid-career GP support, peer mentoring, lots of additional things that we're trying to do to encourage people to stay within the general practice profession. So getting on to access, I think one of the things that we do recognise is just the challenges around getting through on the phone. So I think Councillor Murray, as you recognise, is that there are different ways of being able to access services. So I think it's important to set the context, though, in terms of number of appointments. We are delivering more appointments than ever within general practice, and that has been consistently going up since the pandemic, year on year. And 2/3 of those appointments are face-to-face. So we do recognise that there are more appointments that are being also dealt with via virtual means, but there is still a significant proportion that are dealt with face-to-face for those patients who really need it. We've also upgraded 98% of our practice phone lines to cloud-based telephony systems. So again, trying to improve that access for patients through the phone lines. But actually, as we mentioned before, online consultations also help potentially people to access services without needing to go through the phone lines, and free up those phone lines for people that really need that access through that means rather than digital technology, because we're cognizant that we don't want to exclude a proportion of the population that don't have access to digital means. Again, it just sets the context in terms of where we are. So that's just showing, I guess, how many appointments have been offered in general practice. Each month we do have a proportion that don't attend their appointments, but we're hoping, again, through advancements in technology, we're trying to make it easier for people to be able to cancel those appointments so we can free up that capacity. So again, can be offered out to patients to be able to help meet that demand and need that's out there. We included some detail around the estates, and apologies you won't be able to see it up there because it's in quite small print, but we're looking at our general practice estates and looking at how it supports new models of care. So again, going back into that conversation that we're having around integrated services and how we can actually flexibly work with our estate to support those new models of care. And for Medway, we've got our 4 healthy living centres, and I think it's recognised regionally that it's amongst the best healthcare estate that's out there. So we've got to make better use of that estate, and again, working with our partners to help deliver services from those. One of the things that we again had in the GP development plan was the use of the community pharmacy consultation service. So one thing that's important to recognise is that community pharmacy is a really good outlet for patients to be able to help them with their low acuity needs. On the 31st of January, the Pharmacy First service launched, and they are now able to support with 7 common conditions, and I've listed them there, so sinusitis, sore throat, earache, infected inside by impetigo shingles and uncomplicated urinary tract infections in women's. So there's a new offer, and that's walk-in as well, that you don't need to go via your GP. So again, we need to promote that to the public, make sure that they're aware of how to access that. And similarly, as we mentioned with the additional roles, it's about building confidence and trust in that service and making sure people are aware of how they can support them. But we have seen some really good uses of the community pharmacy throughout Kent and Medway, and Medway practices themselves made over 10,500 referrals since April 2022, freeing up over 1,750 hours of additional appointments for patients who need to see a GP. Just, Councillor Murray, you mentioned the GP task group. One of the things that we recognised from that, and there's a recommendation that came from the group, was about how we share best practice. So we did hold a celebration event where we had the opportunity for practices, PCNs, to come and share their successes. And we were pleased to see that Maritime Health Partnership were able to demonstrate the work that they've done with community pharmacy, that close working relationship with community pharmacy, looking at their triage model in-house, care navigation, and how they've upskilled their teams. And it's really delivered some significant benefits for their patients, and we've captured some of the patient feedback that's been received as a result of that. So again, the practice have worked really closely with their community pharmacies nearby them to make sure that they can offer that service to their patients. And again, we've been able to share that learning with other practices and PCNs across Kent and Medway. And that just shows the number of referrals that they've made from January to October 2023. I just wanted to set this in the context, I guess, of, so we've had the GP development plan, which run for 2 years, but where are we now and where do we go? So we have a national recovery plan that we are working on. So a lot of this kind of does line quite nicely with some of the stuff we've been talking about. So how can we empower patients? Some of that is through digital technology, but also some of it is improving self-referral pathways and helping patients navigate their way through the system. The second thing is how we modernise access to general practice. So some of the stuff I mentioned about telephony systems, care navigation, recognise we need to build capacity, and we're also looking at how we can cut bureaucracy. So particularly looking at things around the primary and secondary care interface and how we can make sure we hold that patient in the middle of that journey and make it as seamless as possible between both parties. And we're developing our primary care strategy. So this is, as many of you are aware, we've been doing some engagement work over the last 6 months just to engage with the public. And one of the key things that we heard from the members of the public was actually they came up with something called the 6 C's, is what they refer to it as. And actually it aligns really closely with some of the stuff that we've been talking about. So they want clarity on the services that are available to them and how to access them. They want effective communications. So how can we communicate effectively to all our population? How can we deliver consistency and have that core offer available to patients regardless of where they live? How can we protect continuity for those who need it? How can we deliver and create capacity, so there's a recognition that we have challenges around capacity? And then also, how can we make sure that we deliver services within our local community which meets our local community's needs? And as we develop this strategy, it's one of the threads that are coming through that we're trying to pull through into everything that we do. Ash, I don't know if you want to talk through the model of care that we've also been discussing with the public and with our providers.
Thank you. And as Suk mentioned, I'm Dr. Ash. I'm a GP by background and jobbing GP, and also the Deputy CMO for Kent and Medway. And I'm working with Suk in trying to develop this new or a primary care strategy in terms of which is going to take us forward from here. As a part of that, we looked at our models of care. When we talk about models of care, there are 3 areas which came back strongly when we had the engagement with the public, with yourselves, with a lot of our clinicians. They said to us, as the 3 areas they want us to focus on is access. Usually, most likely they would have said access and access, but they said access, and I think I do recognize they said the proactive care in terms of how do we help manage the long-term conditions far better than we currently do. For example, somebody with diabetes, somebody with asthma, somebody with COPD. How do you do things better? And the third, and this is not a surprise, is prevention. How do we stop people from actually getting those diseases in the first place? Or if they're going to get it, make sure that they gets delayed. So our whole model of care is based on that. And in terms of access, I think the feedback we were getting was we want to, they really want to make sure they really want us to see somehow we can protect the continuity of care for those patients who really need that, but also for those who just need a transactional care. I've got just a cough and a cold. I'm a 25-year-old fit person. why do I need to go to the same person again and again? What kind of access can I get in which I can have that transactional care? So they want us to look at access in this way. Again, as I said, proactive care, they really want us to talk about not just into siloed ways of working. One of the feedbacks we're getting in models of care is how do we all work together? And this is for health and the care to come together to work more effectively in terms of how we deliver that. And same message we're getting for the prevention is the model of care has to be an all-encompassing preventive model in terms of not just the health on its own, but health and care coming together to make sure that it happens. And then we looked at various enablers. The key enablers, for example, like digital, the estates, the workforce, how do we bring them together to make sure that this becomes all effective? So as we develop our models of care, we will make sure that these three areas which have been a challenge, which have been given as a challenge to us, we're able to address this together with your help. Move forward.
Thank you very much, both of you. And I think one of the first things that we should do from the board is to send formal congratulations to the Maritime practice. I was very pleased to visit them and see the level of modernisation and actually the level of fantastic training for the people who work there, particularly with the telephony system. And I think that, you know, the key to that, I was also pleased to direct the BBC to go there when they did an item that I took part in earlier this year, and they were very welcoming to the BBC because that's important in terms of improving the confidence of the public. I think in terms of that transition to some of these new technologies, you know, the key to being successful there was putting on a really good training program for all of the staff. And then one of the things that the team who dealt with all of the calls told me is that the trainers then stayed with them for a month, helping them troubleshoot, helping them, you know, still pick up things even after the initial training was over. And some of those people had been at the practice actually for a long time and were quite scared of what would happen when they moved over to the new system, but in fact had complete confidence. And as such then, listening to what they had to say to patients, their patients had confidence in what they were telling them. And I can tell everybody around the table that is an extremely skilled job. You're looking at 3 screens and managing them all. So, you know, we mustn't forget people who work in the background either. I think, thank you very much, both of you, for your report. And look, we see the scale there, don't we? 9 million appointments. You know, not forever, in a year. It still is a huge, you know, that's a huge amount, and that's happening all of the time. I'm interested around the table in any ideas that you've got about how we can improve public confidence and access, actually. So if anyone's got any ideas about that, I know a directory of services is on your list there, but if there's anything else that we can do, I think that would be a good direction. And also, the GP attraction scheme is working. I've got a new GP at my surgery who I've spoken to at length, who felt very welcome in Medway, has settled here, really took advantage of the attraction scheme. And James, we were able to identify someone else, weren't we, from the medical school, and put together a little video of that person being very happy. So these things are working. I'd just like a bit of assurance that the skilled worker scheme, the people on that have got the same level of mentoring and support to keep them here, because it's a big move coming from another country to work here, especially in what can feel like a bit of an unstable world at the moment. So if you can just pick up those couple of points, then I'll come to questions. Thank you.
May I come back on the second one? In terms of the skilled workers program, most of the people we take on the skilled workers programs are those GPs who are in the training scheme, and they're coming at the fag end of their training scheme, and they don't have a visa to carry on and stay in this country. So they're already a part of our society. They're already part of us, and they're quite well established in the system. So but what the challenge for them is, if we are not able to get them, some other area will, or they might have to move back to the place where they came from. So it's good that we have the schemes in place. It gives them a reassurance that they don't have to move on from the area. And because they've already been in the scheme, they've already become part of the society per se. And so that in that way, I'm quite reassured with regards to that cohort of colleagues of ours, because one of my neighboring practices has just taken on a colleague of that in a similar situation. And that person was very grateful because he was on the verge of moving from this area. So it's good that we're holding on to our colleagues back here.
Thank you very much, Ash. So you wanted to just add
Yeah,
something?
just on the attraction package, I was going to just cover, just to give a bit of an overview really. So we've got an evaluation that's taking place, so it's a bit of just understanding, I guess, what's worked, what maybe hasn't worked as well. But I think there are some things that we've collected through this program. So, for example, there's a load of materials that all practices can use for their recruitment of GPs, because there's all kind of literature that they can borrow, kind of templates that they can use when they go out to advert, which anyone can use, regardless of whether you're in Medway, Swell, or Thanet, or anywhere in Kent and Medway. There's some really good materials that we've captured. But also one of the things that I do want to have a look at is an opportunity to expand this into other areas. So it doesn't necessarily be just GPs. There might be things around dentistry, for example, that we could look at with a similar program and a package. But again, making sure that you've got the benefits of the financial package, but also that education, training, development opportunity for someone coming to work in any of the areas in Kent and Medway that we've identified. So I think this is almost like the phase 1 of the programme, and there'll be a phase 2 that we need to start looking at.
Thank you. Hazel, please.
Thank you, Chair. Thank you, Chair. Thank you for the report. I'm going to do a Stephen on it. I'm going to do a little bit of history. Councillor Prenter and I were part of a focus group when we talked about putting the patient in the centre of this and getting away from the idea that everything had to be a GP provision. Now, GP services, yes, but the single GP didn't have to see every patient, and that was where we started off in this focus group. Now, I see that great progress has been made on a lot of the enablers, and I think that one thing that we really need to add on this is another C, and it's called cost. And it's the cost of the lost opportunities that we have of actually redirecting patients to the right pathway. Because if I only need to see a pharmacist for a couple of, painkillers with a throat infection or something like that, I don't need to see somebody who spent, time becoming a GP, because we have other pathways. And being the age I am, a lot of people say they have to go to the GP for very minor ailments, or even quite serious ailments, but they need triaging, because the GP does a lot of triaging. And what I'm suggesting is use every methodology you've got to encourage people like of my age group particularly, because you'll get the 25-year-olds that will press buttons. But people like me need to be told time and time again, you don't need to phone a doctor for this, guys. And the one time that you'll probably get long-term benefit out of this is at your pharmacy end, because people like me take pills, tablets, inhalers, various other things, and we pitch up to collect our prescriptions. If there is a reminder every single time that there's another pathway in. I've had this discussion with some of the age groups that I meet through my work as a counsellor and in my private life, and a lot of people say to me, I need to see the GP. And I say, no, you don't. You need to see the nurse about that, or you need to see X and Y. Now, if the way into the nurse is through the GP's number, that's fine. Or if there's another way, let's extend that. And what I would like to say, and I want to pay compliments to the medical profession, and in its widest context here. In primary care and through the hospital and various other things, lots of us are still alive that wouldn't have been alive if we hadn't got adequate and correct treatment at the time it was needed. So what we need to do now is to make sure that we celebrate that by just reiterating some of the things that you've said. And I'm glad to hear that we have retained people from Tier 4 visas onto Tier 2. Sorry, that's a bit technical, but it's basically from being a student into being able to work here. I would suggest that maybe we have a vehicle in some of our universities as well, and that we we see how you can extend that to other skilled workers, not just your GP cohort. And
Hazel,
thanks again.
Yeah,
Sorry
thank
if
you.
that was a bit long-winded.
No, thank you, Hazel. Some really good ideas. I'll take Eddie and then come back to you for comments. Eddie.
Hello, that was very interesting, a very interesting report that really does put the sheer scale of things into perspective. I would like to ask a couple of questions. I've done some notes here. In the name of trying to be being positive, start that way, I do think it's a very good idea, the expansion of the use of pharmacists. I was wondering whether that can be expanded even more, and also the use of advanced practitioners and other people. However, I do get a little bit confused with, I have a pharmacist from my, my practice, and she can initiate prescriptions after we've had a meds review, everything apart from one particular medication. Now, I appreciate the whole issue about addiction, but if she's qualified to do that, I don't understand why then she has to refer that to a GP. There's quite often a delay. I quite often don't have to chase, and the people you're chasing are under a lot of pressure. So I literally just don't get the logic behind that, so I would like that to be thought about. Now, you said in your presentation that I think you said the word a celebration meeting, was it? That you had with GP practices, some event?
Yeah, celebration events.
Yeah, that's very good, because obviously positivity is a very powerful tool. However, when you have a GP practice that is failing, in other words, cannot meet or see their people in their books, do you have a support mechanism, please? You came out with an outstanding figure for how many people you see face-to-face. Not in my practice. I've had two operations in the past 2 years. I have not even seen my GP face-to-face, no matter how many times I've asked since then. I've seen the surgeon at the hospital. Now, if I refer to the idea there's a flavour in meetings, I'm not sure if that's a word you recognise. You go to your surgeon. Are you okay? Yes, I am. Any issues? No, there isn't. I will sign you back to your GP. Because that's his job. You go back to your GP, can I get an appointment? So 2 weeks after my operation, I had the 2-week review with the nurse. I contacted the triage to my practice on a Wednesday afternoon. This translated in an out of hours on Saturday, and his whole attitude was, I'm out of hours. I cannot engage in the conversation you want, which was, can you give me advice about post-care and about pain relief? He was not interested, and I felt he was rushing and just fobbing me off. All I can do is go to the script. You're talking to out of hours, you should be talking to GP. I said, I did not ask to speak to you on Wednesday afternoon. You know, this is appalling, and this is only one of many examples. So I believe that my practice is failing, and I'm just wondering whether you can actually give people like this a support, please.
Thank you, Eddie. Now, just before I come back to Sukhanash to respond to those two things, I've got 4 more speakers, 5 more actually, and this is only our first item. So I'm going to, I've got Caroline, I've got Simon, I've got Andrew and Councillor Hackwell. So I'll make that our lot there, because obviously we can come back to this. And what I would say on pharmacy, so I think perhaps we might have a discussion about a special meeting to pick up on how pharmacy first is going, and maybe get some representatives from the pharmacies along. I think you're right, Eddie, about that, and Hazel as well. But we're asking quite a lot of the pharmacies, so I think maybe we won't deal with that in very much detail today, but that's something that we could look to do, because I'm conscious of 2 things. One, we're asking a lot, and 2, the spread of pharmacy provision is very inconsistent, and I'm worried actually about the peninsula, where there's not such good provision, if I can just say that. So I'm asking you now to respond fairly quickly to Eddie and to Hazel, and then I will come to Caroline, Simon, Andrew and Councillor Hackwell in that order. Okay, thank you.
Thank you. I will start with Councillor Brown. Thank you, Councillor Brown, for your kind words. The 2 things which I took away from that was, one was empowering our patients. It's about trusting your patients to make the right judgment, and I completely agree with you that I look after a lot of my patients who are, as you described, in an sort of an elderly age group. And a number of times they have surprised me with the decisions they're taking in terms of even their digital technology know-how sometimes is better than mine. So I trust them a lot of times to make the right decision, so it's about empowering that. And as one of the slide decks, we talked about how do we empower the patients to make the right choices in terms of what services do they need. That brings me to the second thing you talked about, pharmacy, and that comes to your question about pharmacy first. We have, in last 1 year, we have got what we call as a community pharmacy clinical services, as CPCS services, which we just talked about there. That has been running for some time already. As a next step from that onwards is then pharmacy first. So where they can treat and look at you for those 7 defined conditions. So that's just come in. So that's the, as you said, Councillor Peake, that's the next evolution of what the pharmacy services can be able to offer. Once that is embedded, then comes the question of what else could we ask our pharmacies to do. But we have to be mindful of the fact that we can only shift the work for which they are able to, are in a situation to deal with at present, because they also don't have infinite resources themselves. So we just need to be very careful on that. So hopefully with the pharmacy first, once it gets going properly, we will be able to, as you just said, Councillor Murray, review it and then have that discussion in terms of how things are progressing and what else can we bring forward for that. Yep.
And just I guess the point you made about practices that maybe aren't as thriving as Maritime Health and maybe have particular challenges. So we do offer support. So we have a GP support and improvement program. And what we're trying to do is have conversation with all our practices to understand, I guess, what their challenges might be. So some practices might be around workforce. They are trying to recruit and they're struggling with that. So we offer some support through that. Others could be quality issues that we help them with. And also, if any practice has a CQC inspection and there are recommendations or actions that come out of that, we as the ICB would also be supporting them with some of those recommendations as well. So there is an ongoing programme of improvement that we're trying to work through with all our practices, but it will also target those that might need a bit more support than those that are maybe flourishing in other ways. So we're also mindful that we don't allow, I guess, a situation to occur where some practices maybe aren't as able to progress to the level that maybe Maritime Health are. So we have some stuff that we've got to do and help and support them through that journey.
Okay, thank you both. Caroline.
Thank you. I'm Caroline Rickard, I'm a GP, and I am here as one of the medical directors for Kent Local Medical Committee, so we represent GPs across Kent and Medway. So thank you for the report, which is positive and represents investment into something called the PCN-DES, which is a part of the contracting mechanism for general practice, but it's an additional part. The core funding that practices receive is through something called to deliver GMS services, the general medical services. So while we've seen a massive expansion in numbers of additional staff, we are hearing from practices that at practice level, some are still struggling, and this is probably why we still see some differences between practices. And there's a few things that are causing the challenges at the moment. One of them is estates. So when you suddenly expand your workforce, you need rooms to put that additional workforce in to work from. And the other point of expansion, which again is entirely welcome, is trainees. So we've got more medical students and we've got more roles that we are supervising. And so practices are struggling with their estates to maintain the room to see everybody in. And the other point that practices have raised to us is that currently at this point in time there is a lot of financial uncertainty. So the PCN-DES that has brought in the additional roles comes to an end, and so there are currently we're waiting for NHS England to advise us as to what the funding is going to look like in the future for general practice. GPs are still employed at practice level, or they are a partner. So practices are independent contractors, and it's that amazing agility that independent contractors demonstrate with Maritime Health, where they can definitely mould their services to suit their patient population. And the other point around, sorry, I've just completely lost my thread. So we, the financial uncertainty that practices have at the moment around what the financial funding is going to look like in the future they're finding that to be prohibitive. At the same time, they've had an increase in their practice running costs. So while we've seen a lot of positives, I think at this point, practices want us to increase the core funding at practice level to enable them to expand their estates and to expand the GP workforce.
Thank you very much, Caroline. And before perhaps Suk and Ash, you come to that, you've mentioned estates at the end of this presentation. It's a bigger issue, I think, right across the primary care community than it appears to be in this report. There's a national dispute, I think, isn't there, about rents for and maintenance fees for some of the healthy living centres, and I think that does merit a special focus. I know that the ICB are actually focusing on that, and we've got Mike Hewitt in place doing that particular work. So that work on estates is coming. It's a very valid point that you've raised, Caroline, and causing me some concern, along with James and along with actually lots of other people. And we don't want all of these good strategies and initiatives to fall over on the basis that people haven't got anywhere to go, or that they can't afford to. So I'm not expecting you to, solve that problem now, but I think it is important for the board to raise that as a serious concern, and something that I think merits us coming back on, please, Stephanie, in terms of what exactly is being done to resolve some of these issues. So not expecting an answer today, but very aware that it's actually stopping people in their tracks. So if you just want to come back on that one, because I think it's, Caroline's raised a really important issue there, then I'll come to Simon, Andrew and Councillor Hackwell. Okay.
Yeah, so I recognise the concerns that Caroline's raised, because obviously we've heard some of those challenges. With our health and care partnerships, they are developing clinical and estate strategies, and in fact, I think we'll be coming to Medway's HASC in July or August to give an update in terms of where that programme of work is. So I think that will hopefully give some direction around what we are doing to try and maximise the use of our estate and overcome some of the hurdles and obstacles that you've just mentioned. When we're also doing the strategy work, I think we've always been keen to make sure that we tie up what you mentioned about training, digital, workforce and estates, because they all have an interplay, because the way your model of care, the way you deliver services will actually impact on what you need in terms of estates capacity, and then we're trying to do this prioritised needs assessment as well, so we understand where our pinch points are across the system and how we can really make sure that we've got focused priorities in place on those areas. But as I said, the Medway and Swell HCP estate strategy should hopefully give some direction around that anyway.
That's very helpful, because I think for the public, the last thing they can understand and appreciate is when things are pressured, why are the healthy living centres appearing to be empty? And I think for me, I've got a very, Caroline, for your reassurance, and from Labour generally, a very personal stake in those. They were built under Labour. They were always intended as multifunctional clinics. The facilities are very, very good. And, it's interesting to hear, Suk, what you said about the quality of our estate in Medway. It is good, but if it's underutilised, that obviously is, not what we expect. Okay, thank you. Simon, please.
Yeah, thanks, Trudy, and thanks very much for your report. I think it's a really challenging kind of report to have to pull together. I think we can appreciate in the council how difficult it is when you're an under-resourced public service, how you then manage that resource in a way to do the best you possibly can. And at the same time as you're doing that, you're also trying to bring about change and maintain the current service while bringing new changes in which will improve it. So it's a sort of quite a complex matrix of stuff you're putting together. On page 19 of the report, we've got those blue bubbles, speech boxes, and one of them obviously talks about access. And in that respect, you're talking about improving access. I've got two questions in relation to that. One is about the access from most people's perspective is either through their GP practice, so they phone up the receptionist and then they get signposted from there. It's an email to the same source and get signposted, or it's their pharmacy, and that's it really in terms of communication access for the majority of people. If they're in the hospital system, then they've got access there, but that's a lesser number of people. So I'm just wondering about how, when you talk about improving access, where are these improvements actually fitting in? Is that literally those three ways in that you're looking at? And also in terms of that access, once you're in the system, I mean, are you looking at ways that somebody can say, okay, if I've been to the nurse twice, do I really have to go back through reception again to get to the nurse, or can I email the nurse direct and say I'm coming in to see you because of my minor injury or whatever? It's that kind of improving access so that it sort of bypasses the need to go through the GP and be referred by GC because of the pressure of work on the GPs as well. So there's one question around access in that respect. The other question I had is about the recruitment that you talked about. That's on the page 22, looking at the, 23, looking at the table that you've got there. In relation to Medway, you've got the December 22 figure, 125 head count, and then jumping to September 23, 141. So an extra sort of recruitment of 20-ish sort of. Is that a result of the new measures that came in January? And is that the benefits we're seeing there? Or was that a general trend? It was kind of, it reached a low point of 119 and then looked like it was starting to rise anyway. So are you confident that the measures you brought in is leading to that result there? I think it is from what I've heard already in discussion, but that was a question I had there. And then going back to the diagram of the speech bubbles, just to sort of focus my mind. In terms of access, again, one of the things you've got there is about the locations and where you commission practice services. One of the things that as a council we're working on, we've got a number of strategies in relation to public transport, walking and cycling initiatives and stuff like that. So we really need, this is a request to talk really more than anything else to the key people about how we make sure that the public transport services are adequate to the facilities that are coming forward, and making sure the existing facilities are well served. I mean, Teresa and I have dealt with an issue at the hospital just recently where things were going a bit pear-shaped and are starting to be ironed out, hopefully. But there is an issue around actual physical access and how we resolve that problem, particularly in relation to, say, for example, if somebody's receiving some treatment and the letter comes in through their door and tells them they have to be in Gravesend on a certain date on a corner of a housing estate where there's a vehicle pulled up there with which is a sort of mobile whatever it is, getting there is usually the only way is by car. And that really does exclude a lot of people. So it's just trying to talk about public transport and the relationship between services. Thank you, Teresa.
Thank you, Simon. So 3 questions from Simon. I'll ask you to take them when we've had the other 2 contributions, if that's okay. Yep. So I've got Andrew at the end, not Andrew Raby, on this occasion, and then Councillor Hackwell.
Thank you. I'm Andrew Stradling, a hospital doctor and interim medical director for the Health and Care Partnership. Just a point and then a question. I think it's worth recognising that it's so difficult to change public expectation and perception of access, which makes this really difficult to measure. But I wonder, have you seen any negative impacts of drawing staff into the additional roles into GP practices? Are there impacts outside in other areas of the of the economy?
Andrew and Councillor Hackwell, finally, please.
Thank you, Chair. Just a couple of questions. First of all, on the 50,000 no-shows, it works out about 5%. Is that normal for the country, or Medway high or low? And do we do any work to follow up with those people to find out why they don't show, and if there's any thread in that that we can actually then improve the services so they show or cancel or something like that? With regard to, I must say you said there's some improvement in telephones. From a personal point of view, I've experienced when you ring up, instead of having to press the redial button because all you got was an engage sign, things seem to have got a lot better. So I do actually appreciate that some work has been done and it has been seen by people that are using that, so I recognise that. And a follow-up what Councillor Murray said about the estates, really. I represent Rainham ward, and our Healthy Living Centre, which you praised to see one of the best, the 4 best bits of estate in Medway, is virtually empty. We have practices moving out. I mean, just recently we've had some services move across the road to the church hall and it's all down to cost. They're fantastic buildings. What are we going to do to make sure that practices can afford to use those buildings? Because it's really daft having a fantastic building in an area which is central, and GPs, and they're moving their practices further out of the town and harder for people to reach. And they're not doing it because the facilities are bad, they're doing it because it's costing them too much to use those services. So it's just a matter of money that we've got to sort out. I know money's difficult at the moment for everybody, but that's what we've got to fix. We've got the facilities, but somehow people are not being encouraged to use them. Thank you.
Okay, thank you, Councillor Hackwell. So if I go back to Suk and Ash for those answers, I think you've got about 6 things there to answer, so hopefully...
Yeah, should I come in first, Ash, and then you want to follow up with anything? So, access. So I think it's complicated, and there are a number of reasons that drive people to access services in a particular way. Behaviour, like you mentioned about patient behaviour, drives some of this as well. So comms, I think, is another thing that we haven't mentioned in there, but that's really key. So again, effective communication with the public. One of the things I was speaking to one of our clinical leads around digital earlier on today was actually the NHS app. So there is a national programme to basically increase the use of the NHS app, but that can be a really good way of helping people who can use the app and have ability to access technology to navigate their way more effectively through the system. So rather than, again, just go straight to your GP, that can upfront try and signpost and direct you to services, pharmacy, self-referral pathways, whatever it might be, rather than you needing to go through to the GP. And there are different models that practices have that they operate to try and meet the needs of their population. And I think what we're trying to showcase through things like the celebration event is that this is a model that Maritime Health have used. It may not work for your population. You may need to have another model that you want to use that kind of better meets the needs of your patients. But actually it's about sharing different models of access and seeing how that can support patients. And that's what we're trying to encourage and do. The GP numbers, where you asked about is it down to the initiatives, and I think that's part of the evaluation that we need to find out, is actually what's driven the uptake. Caroline's kind of articulated some of the challenges around finances that exist within general practice, so they've got to make their budgets work for their workforce as well. But actually things like the GP Attraction Programme, the Tier 2 visa programme, all of these things hopefully are what has kind of led us to improve those initiatives. But we need to evaluate them and then decide actually, should we continue with those? Should we refocus our efforts on other areas or other roles that are needed within primary care as well? Transport would be great to link in with you, so I think the offer's there, and we definitely would like to, I think, explore that more widely. DNAs, so the people that haven't attended their appointments that you mentioned, I think it's quite challenging, because I think that's why we were saying about the telephony systems, is that those people may have wanted to cancel their appointment but couldn't. And it's those kind of things. We need to make it easy for people to cancel their appointments. I don't think we're an outlier in terms of percentage of patients that aren't arriving for their appointments, but we've got to look at the reasons why. And I think you're right, there is a bit of understanding why people haven't arrived and what it is, whether it is behaviours or chaotic lifestyles, things that might be a reason what are driving people not arriving for their appointments. And then healthy living centres, I think we'll go back again to that conversation around the strategy. Again, as Caroline mentioned, it's going down to cost. And actually, from a practice perspective, they're going to spend their money on some of the increasing the ability for their workforce or their estate. And sometimes it's that conflict that exists. Ash, do you want to add anything?
Thank you, Councillor Curry. Thank you, sir. I think, Councillor Curry, you asked a very pertinent question. Is if we're going to keep doing the same thing, how are we going to have a different answer? And I completely agree with you on that. The thing is this, let me give you some numbers, Councillor Curry. We see in Kent and Medway, we see about 1 million patients, almost 1 million patients every month. That's nearly half the population of Kent and Medway. 2/3 of that is face-to-face. The second thing you have to understand is, on the baseline of 2018, we have improved the number of appointments by 138%. Almost with the same number of GPs. We haven't actually gone up in that. We're the second highest in Southeast. So the thing is this, we have pushed it as hard as it can get to with the current model. With the current model, we can't go any further than this. So we really have to start thinking in terms of what do we do differently to get to the answer which you asked me, Councillor Curry, is how are we going to improve things? So some of those things which we are thinking in terms of is, like I said in the beginning, is one is empowering the patients. Like Sukh was saying, and Councillor Curry Brown mentioned about is, let the patients decide what's the best care for them. Maybe NHS app might be one of the answers, but communicating those things to the patients. For example, this is the best service for you. If you want to book an audiologist service, can you do it yourself? Yes, you can. If you want to go for this service, can you self-book it yourself? You can. A lot of conditions do not need you to seek healthcare. Giving the right tips for self-care, but on an app which is easily accessible to you, would be a good option. Then once you need our help, how do we signpost you to the right service the first time? What currently happens is, if I see a patient, then I say, I need to see you a physio. It's basically wasting 2 appointments. How do I get that patient to the right clinician right the first time? That's going to be the key of the new model which we are trying to create. So that's important. So that's what change we want to bring in. And then we also understand, as I said right at the beginning, is about transactional care. Somebody who has got just a cough and a cold or a sore throat, who really doesn't need to see us in a practice. What other options are there to us to give to them so that they can be seen in a transactional hub or a same-day access hub, which we are trying out in Kent and Medway, so that they can be managed in a different way than somebody who has got a COPD or has got an emphysema. So these are different things which we have been talking about. So I completely get your point. We can't carry on with what we are doing, so we need to change. And what we need from all of you is to help us make sure we can communicate to our patients or to communicate to our population is that the models are changing. We need to be able to go and see the physio and accept that if you've got a back pain, the physio is the best person. If somebody has a depression and they're feeling low, seeing a mental health nurse is far better than seeing me. So those changes, we will have to work with you to get that message across. Yeah.
So we have had some chance. So, for example, in additional roles where there were clinical pharmacists going to work in PCNs, that has had an impact on the pharmacy workforce. So I think we have always been cognizant that, I guess, when we are doing this, that we don't have, I guess, robbing Peter to pay Paul. So you don't want to take from one provider and destabilise them. So I guess the position that we want to try to get to is work as a system collectively and trying to make sure that we address the needs of the population, make the best use of our workforce that we've got across our system, but not necessarily destabilise one for the other. But the unintended consequences has come to fruition in some areas. That's unfortunately the reality.
And just learning from that, Councillor Murray, is we have worked with the Mental Health Trust. For example, we have got mental health nurses within our own practices. Now, what we have done is we have shared them with the Mental Health Trust. So it's actually a win-win situation on both sides. So yes, there have been unintended consequences, but critically, we have learned our lessons. And so in some areas, we have made sure that doesn't happen. And what we need to do is to take that lesson learned and then bring it to other areas which we have.
And luckily, we've got KMPT here today, so we might be able to pick that up. Right, that's the end of item 1. So I'll go to the Vice Chairperson just to bring that through. And by my reckoning, Jane, we've got 4 sort of broad actions. Pharmacy and estates are both coming to HASC, so we'll have a chance to have a deep dive into those. Transport offer accepted, Simon, and a very good and helpful one too, coming through the evaluation there. And obviously the funding and the sort of instability, I think we need to consider actually as a board what we do to give a bit of support to make sure that we hear that is coming through. So with that and some of the other things that I'm sure Stephanie's got a record of, I'll go to you, Jane, please.
Thanks, Chair. The only other one that I picked up was about further opportunities in terms of redirection to other services. So that was the only other thing I picked up. So the Health and Wellbeing Board is asked to note the report with those other recommendations.
Thank you. And just as a kind of interesting little aside, Councillor Sharon Jackson is employed to show people how to use the NHS app, and she's been doing that for a group of London surgeries, and I'm going to meet her and go to one of her sessions. So that's something I think perhaps that we should make sure that we see in Medway. Okay, thank you. Right, the next item then is the, oh yes, we need to agree it, so sorry about that, having got you to propose it. Is that agreed, that we note the report with those recommendations?
Agreed.
Okay, thank you. Item then is the Kent and Medway Safeguarding Board's annual report, which has also been to Haskin through various incarnations. So thank you for bringing it here today, Andrew. And I do draw people's attention to the report as a whole and to the very useful case studies that are shared with us, explaining how, very sadly, we've seen some deaths as a result of sort of system failures. And I think it's a very frank report, and there are things, there's a lot of learning from there. So, Andrew Raby, over to you.
Thank you, Councillor Murray. For everyone's interest, my name is Andy Raby, and I'm the independent chair of the Kent and Medway Safeguarding Adults Board. I'm here with my colleague, Vicky Whiddon, who's the manager of the board, and more importantly, is the author of the report and actually does all the research and all the background work that pulls together the report that I have the opportunity and the pleasure to actually come here and present. You'll notice that it's a Kent and Medway report, and it's always raised the issue about, well, what's Medway's part in this? How do we ensure that there's that Medway voice? And we try to make sure that when we can, we actually differentiate between Kent and Medway. So, for instance, you'll see that the data that comes from the national stats is separately identified between Kent and Medway, and actually the examples of practice are also identified in terms of Medway. But very often there'll be crossover. So, for instance, Kent Police and Probation will operate across the borders of both. We're also very lucky to have Jackie as the deputy chair of the board, so we work closely, and Leanne chairs our quality assurance working group. So we have a very strong Medway footprint throughout the board, and I'm pleased in relation to that, and I'm grateful for their support to the board. So the annual report is, it's always a bit of a year back. It's April 2022 to March 2023. So it operates under an old strategic plan, and during that year we looked at a new strategy which we put in place and was launched at the end of last year. So we talk about the achievements against those strategies, but they are similar in relation to things that we wanted to actually cover. So the report's broken down into 4 parts: the strategic plan, about us, priorities and achievements, and the safeguarding adult reviews. It's a big read, I know that, and it contains a lot of information that we have to put in. But I look at it as a booklet, a workbook of good practice, of where we actually have seen good practice across the county and across the unitary authority of Medway, that we can highlight to you all, that you can see, and you can see that how safeguarding is tackled across Medway is of significant importance, both to us as a board and to the people that actually deliver that functionality and that responsibility. So I could pick out my highlights and talk to you about those. I think it's probably an opportunity for you to actually ask us questions about the things that you might want to ask us in terms of the Medway area.
Thank you very much, Andrew. Anybody, please? Okay, Simon, thank you.
Yeah, thanks very much, and thank you very much for the report. There's a lot to take in here, and some of the stories at the end are quite heartbreaking, to be honest, and it is difficult. A couple of questions, really, in relation to the report itself. It's about detail really, well, and perhaps a key point in the middle of all this as well. A couple of key points rather, so I'll just emphasise one. One of your objectives, I think objective 9, is all about partnership working, and I think that's at the heart of everything you do in this. If we don't work in partnership, we will not get the outcomes we're looking for. And that. So I just wanted to say how welcome that is to see that, and obviously it's something that everybody works incredibly hard at, to maintain those strong partnerships across the board within the council and outside as well. And one of the issues there is about the housing. I'm going to mention this. One of the biggest issues, certainly in my ward, and my ward's Luton in Chatham, a lot of issues around the things that the safeguarding of adults and children, to be honest, they're both completely tied together, is about the quality of housing, conditions that the people are living in and stuff like that. Often if they're living in really appalling conditions, they feel unsafe even in their own homes and stuff like that. So the link to housing, and I know that our own colleague Councillor Khan is very keen on this as well, how we resolve that. So I'd just be interested to hear your views on how that works. And the other thing is about data measurements and outcomes. It's a really complex and difficult area. And measuring success is not easy, and I'd just be interested to know what approaches you take to how you go about measuring success. Thank you.
Thank you, Simon. Okay, and did you want to come back on that?
Yeah, sorry. A really important point in relation to housing. And yes, housing is key. And we see a diminishing number of housings available for people in terms of social housing, in terms of giving someone somewhere to live. And actually, it does impact a lot in relation to into the work we see and how we actually can identify where people fall into the need. The risk area can often be around those basic principles that people have in life: somewhere to live, a job, and actually, as we've been talking, good healthcare and well-being. And they are really important principles that affect safeguarding. And I think it's right to raise it, it's right to challenge it. And I know it's a national crisis, and it's something I think that we see time and time again. You know, homelessness is on the increase. We did some work particularly around prison releases, homelessness, and safeguarding adult reviews and deaths. And you know, you're right to highlight that some of these presented safeguarding adult reviews are tragic, are absolutely tragic. And sadly, we continue to see similar things come in reported to us. But I just want to pick up on the point about partnership. Partnership is absolutely critical. And I know we talk about it all the time, but we are about partnership. Our being is about bringing agencies together to ensure that we press them to say, look, you need to have a better collaborative approach. I've been doing, as well as this role, I've been doing safeguarding adult reviews, domestic homicide reviews and serious case reviews for 10 years. And I can say that collaborative approach is the commonality of failure. It's not about, at times, individual organisations that do a fantastic job. It's when the person that's actually the centre of that issue is actually passed from one to the next where the failure occurs. It's those gaps. You know, we were talking about the GP practices and people that don't attend appointments. And yes, it's a really important point because it's about effectiveness. But the reason people don't attend appointments isn't just because they don't want to go. It's because of the lifestyle they live and the difficulties they have. And sometimes those issues are overlooked, and then they drop through the barrier, the slates, we want to call it. So I think it's a really important point. I'm going to just pass over to Vicky, who wants to answer the second part.
Is that working? Yep. Okay. So yeah, in terms of data management and outcomes, that is something that we are always looking at and always looking to improve. I work really closely with Leanne on this as part of the Quality Assurance Working Group. One of the big measures that we have as a board is our self-assessment framework, where we set the standards and we ask people, you know, what are you doing, you know, as your agency to meet those standards. We're increasing the agencies that we ask, but we're also being more challenging in terms of, and so what? So, you know, we have that data, for example, in relation to, you know, we've raised awareness of safeguarding, we've circulated this poster, we've been here, and we're sort of, and what difference is that making, you know, and then we're asking people to talk to their frontline staff, you know, we update our policies and procedures. We need to know that they're being heard. So it's that sort of pushing that. But like you say, it's incredibly difficult to measure that sort of cause and effect relationship. So for example, the number of safeguarding adult reviews we have is because we've done quite a lot to raise awareness of it. So it's, you know, is it, you know, cause and effect, isn't it, in terms of the sort of numbers of concerns that are coming into the local authority? Is it because we've done such a good job of raising awareness of what safeguarding is? And so that there are more coming through, but also we sort of unpick those figures as well. So actually when we look at the conversion rate, so if there are a lot of numbers coming in and they're not necessarily converting to those section 42s, what's going on there? So we use a lot of that sort of data analysis there, work with our partners on what makes a good referral so that we can make sure we're making the best use of time. So we're constantly doing stuff, and you'll see in our sort of plan as well about the sort of different data that we want to start to get together to sort of analyse that as well. So it's a tricky area.
Thank you very much. I've got Jackie next, please.
Sorry. So from a data point of view, obviously each local authority is responsible as the lead for safeguarding. So from Andy and Vicky's around the safeguarding board, they look at things collectively. We're actually required, well, we're not required to, we should ask people about their desired outcomes when they're alleged victims. And that's something that we do as a council. So I've got an example, you know, of 81% of people that expressed a desired outcome, 84% of those people were, we achieved that outcome. So we can see internally the work that we're doing, whether it is meeting people's outcomes or not. If they respond, they don't have to. With regard to the, if there's a safeguarding adult review, so that's gone through the Kent and Medway Safeguarding Adult Board, and there's an action for the local authority or for partners to look at what can we do to improve to ensure something doesn't happen again. We look at the impact, so how do we make sure that the actions that we're putting in place as a local authority or our partners are putting in place, how do we make sure that our social workers aren't repeating, you know, if there's been some errors or some challenges, how do we make sure that they're not repeating those errors, and we're looking at the impact on that as well. That's something actually we only had a conversation about yesterday, and how do we do those measures. So although you've got that from the Safeguarding Adult Board, you've also got it happening at the council as well.
Quickly, Simon.
Yeah, just very quick. It's really helpful to know. Thank you for that. Because one of the things that we see as councillors often, we'll get a piece of casework come to us. It's involving safeguarding, it's involving somebody who's got some serious problems. And often what happens is they end up leaving our ward, and then we don't see them again. We don't find out the result. But knowing those sorts of figures and how you deal with it, it's really helpful. So thank you for that. It's good.
Sorry, can I just say, just on the back of that, and it's important to understand this, it's the role and responsibility of the board to ensure the quality of delivery of safeguarding across Kent and Medway. So we need to know, we demand to know, and it's written in legislation that I can ask for it, information related to safeguarding, and we do get good returns from Medway around that.
Thank you. Eddie, please.
Oh dear. I appreciate everything that you said. There's obviously great value to reading something in an academic terms, so I'm not knocking what you've written here, but I will refer to personal experience. In the residence where I work, there's been 2 people that have passed away. Both of those people I raised safeguarding, and I was appalled at the lack of support and response I got. So to give you an example of the last person, I raised the safeguarding. I said, this person is not eating very well. I don't think he's taking medication. Now, they officially, and I'm very cynical about this, had capacity. We do not monitor medicine. I raised the safeguarding officer, what do you want me to do? I want you to come and visit this person so you can see them and speak to them. I have these issues. Has his weight been checked, GP? Yes, it has. And officially, he's not underweight, because he's always been really underweight. And this conversation went nowhere. And I don't think the safeguarding officer understood mental health, and there is a difference in understanding with people that have mental health. This is somebody who's very, very good at saying what he thinks you want to hear. But at the same time, when you speak to him, he'll start talking to somebody who's invisible in a third conversation. Anyway, in the end, she said to me, what do you want? I want you to come visit. So that it was left like that, and then it finished with an email saying, this has been reviewed to my manager, we see no case for pursuing this. So it did not happen. Within weeks, that person collapsed in the park and died. Part of the analysis was that he was not taking his medication. The other person died at the home with somebody I raised safeguarding. He was a herring at a ditch.
Sorry,
oh, sorry,
Eddie, I think we just need to be careful for your
too much
protection.
information, sorry.
Yeah.
I'm just concerned about, I appreciate that you are monitoring as a board, but I am concerned because of my own personal experience about, so I don't want to be rude, and it sounds rude, I don't mean to be, but the effectiveness of this, I mean, I don't even know what the answer is, how you would be able, how you're not even going to know about these cases, are you? So.
Effectiveness is really important, and we do actually what you're actually asking. We make sure we know about, so we know that the processes are in place. So for instance, the fact that a safeguarding alert can be raised, and actually it's raised to the local authority, and how that's dealt with is something that we deal with time and time again, and we question and we analyse. If you look in the data we've got with the SAC report, it gives you the numbers of referrals that go into the local authorities. We look very carefully at that, and we say, so what's actually happening with this? So one of the pieces of work we're currently, and what you've got to remember is, although we highlight about practice, we don't deliver practice. So we can only say to organisations, you need to be looking at this, and this is the evidence that we've got that says you should do something about it. And we present that, and I do present that on a regular basis. I'll give you an example of when we do that. But I want to just tell you about something we're working on at the moment. One of the things that concerns me with referrals into the local authority is actually the number of people that are referred in over and over again, not the actual number of cases, because Andy Raby, could be referred in for something that doesn't hit the criteria to be dealt with on one day. Day 7, the same thing, not hit the criteria again and again. We need to start looking at the individuals and actually focusing around how do we deal with individuals that actually have complex, co-occurring conditions that actually impact upon safeguarding that sometimes don't hit the threshold at the first time of hearing. So we're talking about a thing called a MARM. So it's a process where we identify the most the most at-risk people and highlight how we can deal with them on their own and deal with the things that you're talking about, because they're very often complex issues. They're not just one or two things. And we can only, through the evidence, and I am an evidence-based person, and so I don't like to present to any organisation without the evidence to back it up. Hospital discharge is another area. We presented to the ICB our concerns about the continuing issues around hospital discharge of people being discharged home that were then either dying or coming back into hospital again. And we presented to the ICB and actually identified that a piece of work needed to be done as a result of that, and that's ongoing as we speak. So the board does have teeth. It does deal with the very things that you're speaking about, and I do speak about these things on a regular basis. I also meet with mental health groups. I meet with members of the public, and I actually listen to what people tell me so I can feed back real-life situations. Because what you say is absolutely right. You can talk about statistics, you can talk about data, but what you really need to get into is the reality of the situation and how that's addressed. And we do that, I think, quite effectively in relation to our board.
Thank you. I'm going to go to Jackie, please, on this one, and then come to you, Hazel, okay?
Yeah, thank you. Thanks, Councillor Peake. I mean, I'd be interested to have a conversation with you about these outside of the meeting, because those referrals would have come into adult social care into my division. I think one of the things that we need to do some work around probably is around thresholds. Andy's mentioned that. Sometimes people will flag something as a safeguarding, but it doesn't actually meet the safeguarding criteria. So you might think it's something, or I may think it's something, but actually when you look at the legislation, it doesn't meet the criteria. So it may needed to have gone down a different route. So I think it's just we need to do some work around that. But it would be really good if I could have a conversation with you separately about those.
Thank Thank you. And just for your assurance, Eddie, in Adult Safeguarding Week, you probably remember, we did a big promotion about how to make a referral to the public. We had a stand in the Pentagon and elsewhere. I attended the stand in the Pentagon. And in fact, there was a lot of interest from the public, both in terms of the fact that it's something that they can get involved in at all, and in the publicity and information that we had with letting them know how to do it. And I think you're absolutely right, Jackie. It's the thresholds that blur the boundaries, isn't it? And we maybe need to think collectively how we can be clearer on those and get the directions to the sources of help right. Hazel, please.
It's a very quick question. And sometimes it's been partly answered actually by you, Teresa. But my thoughts around safeguarding, because safeguarding is everybody's responsibility. Have we been able to work with some private sector people around this? Because we've mentioned that housing is one of the biggest problems we have with health. And I'm just thinking in the private rented sector, a lot of the time the intermediary between our residents and the landlords is actually estate agents. And it might be that if we raised awareness there, we've got a conduit to help. I'm not trying to give you any more work, Jackie. I'm just trying to find a conduit into it. Just making sure that we don't miss any people that we might have missed.
Hello, yeah, thank you. It's a very good question. We're always trying to increase the reach. We do link with housing as much as we can. We're building our links all the time to lots of different organisations, and so we've included in some of our safeguarding adult reviews as well. Actually, we've had really good representations from sort of some of the housing companies and private providers, and so we are trying to make our tools. We've got a comms and engagement tool, and we share that as far and wide as we can. So anyone here that wants to help with that as well, because we've almost got the sort of a toolkit to hand over to anyone to help with us in sharing that, because as a team we're very small, so we're just sort of, it's about sharing that out. And you know, during Safeguarding Adults Awareness Week as well, we try and get to as many people as we can. We've looked at different offers of training as well to try and get to people and sort of how we can increase training. So we do run a few sort of events now that are open to absolutely anyone, and we've got some new training managers who are going to increase that kind of relationship building with wider partners as part of their role of work as well. So thank you.
Thank you, Victoria. Just before I come back to Jackie, if you've got anything to say, I mean, it's really important to think about that sharing, and I guess as an action for us, we perhaps need to consider where we're sharing that link to that tool and how we do it. And absolutely on housing, I mean, we're very hopeful that our new private sector licensing scheme being piloted in Luton at the moment, but for all the reasons that Councillor Curry alluded to earlier, can scoop in some of these things. And already I was lucky enough to be able to talk to the two people who are running the licensing pilot. That was absolutely definitely something that they had picked up. And I think we have to say to private sector housing providers, along with our social and affordable providers locally, there is this thing that you've just said, Hazel, safeguarding is everybody's business, needs to be absolutely part of that. So sharing the tool, making it clear that this is not just a sort of silo that only a few people are in, I think it is really important and something for us to take as an action today. Jackie.
Just to sort of finish off, really, I think Leanne's just implemented a Adult Social Care External Partnership Board. So it's a broad range of people, and we'll be looking at everything adult social care, but obviously safeguarding will be included in that. So that will enable us to start reaching out to some of those areas. I work very closely with Mark Brethwick as well. Mark's fully engaged and obviously has meetings with private housing providers and so on and so forth. It's definitely making a difference. We've had a 69% increase in safeguarding referrals over 5 years. So if you think, about how many people are now reaching out to us, that's a significant amount more.
Sorry, can I just add just one quick point? Is I think the reach is really important, and we do a lot of work around this. We have a very up to date, and it was complemented by the Medway CSB yesterday. Our safeguarding website is really up to date with lots of information and lots of detail. We also publish and share a newsletter which goes out to over 300 individuals and organisations, which goes out monthly and provides lots of data and detail, and information around safeguarding. So we do, and we also do webinars. We do quarterly webinars which are free and open for anyone to attend on an evening, usually a Tuesday evening, and we have topics that are relevant for people to come along and actually listen to and ask questions about. So we do as much as we could do more, we always could, but that's something that's really important to us and how we work.
Thank you very much, Andrew and Victoria. And the webinars are really good. I've attended one of those, and I think we could do more probably to widen access to all council members, at the very least, apart from this board, about the availability of those webinars. So with that, I will go.
Thanks, Chair. So the Health and Wellbeing Board is asked to note the annual report.
And we've got a couple of things on there that we're going to do. And is everybody happy with that, with the inclusion of those things about extra sharing, looking at training and making sure that we widen awareness? Everyone happy? Okay, thank you.
Agreed.
Right, we'll move on then, please, to Adrian and Sarah. For your report from KMPT, and just to remind people that we wanted to have a special focus at the Health and Wellbeing Board on mental health, and the next item is David Whiting's own report about the kind of state of the nation on that as far as it goes. So we'll probably see both of these items together. And I think we've already heard a couple of things for you to pick up, perhaps the placing of mental health practitioners in GP services. It would be helpful to hear about that. Thank you.
Thank you, Chair. So I'm Adrian Richardson. I'm the Director of Transformation Partnerships for Kent Medway Partnership Trust. I'm not joined by Sarah today. She sends her apologies. She's on annual leave. So obviously I will take the paper as read. What we've aimed to do today is provide an overview. We're aware that it's been some time since we've provided an update to the board. So we're happy to explore and concentrate on any areas either today or going forward. Last year we set out our new strategy around our patients, our people who work for us and our partners, and then this year we've articulated what those 6 priorities are for ourselves and for our patients. The 3 that I will point out for today is our community mental health framework, which is probably the largest piece of transformation that our community mental health is going to go through in a lifetime, looking at our mental health together and a mental health together plus model with 12 pathways bespoke, aiming for no wrong door, that is a needs-led service, with a holistic approach to that. I'm pleased to say that we are aiming to, and we are on schedule to launch in Medway at the end of Q1, beginning of Q2, following a successful the initiation of a successful pilot in Thanet. So that is going to really revolutionise how we give mental health services, working collaboratively with the VCSE sector as well. I've also pulled out in terms of where we're aiming and setting out our ambition to improve our dementia services so that our patients will receive that diagnosis and then are tapped into services where necessary, and we're working very closely with the ICB on increasing the DDR, the dementia diagnosis rate for Kent and Medway, and utilising a number of GPs with enhanced roles and faster diagnosis in the care homes. And this is also included in the advanced roles that Ash was talking about earlier with regards to and the popularity around those enhanced roles. And then the other third one being flow. Flow remains an absolute challenge for us as an organisation, as other provider organisations. We came out of this weekend with 67 patients in our beds who are clinically ready for discharge, who no longer need to be in beds out of a bed stock of 250. So it's a significant challenge for us that we're working as collaboratively as possible to try and improve. And we've had a number of initiatives that we're working with alongside the ICB and Medway Foundation Trust, in particular with a launch of a safe haven, which is co-located on the MFT site, that only last month redirected around just under 100 patients from the ED. Now that does seem small numbers, but those small numbers are actually quite complex patients to manage in an acute hospital setting. So it's aimed to relieve that as well. We've also included in the report our ongoing work with regards to with physical health checks for our patients, and that we are growing a number of physical health nurses within our staffing base. We continue with our tobacco dependency and our smoking cessation conversations across the organisation, and we've also included in the report details of our review of our service user and patient engagement strategy that we will be looking to refresh this quarter. So that it actually addresses the needs for our populations, and we've also included other initiatives in line with addressing some of the health inequalities, such as exploring the health equity fellowships with our Health Innovation Kent Surrey in Sussex. I'll pause there and happy to take any questions.
Before I take questions, thank you, Adrian. It's good to know that there's transformation going on in the service, and I think it's important for us to acknowledge and recognise that mental health is one of the areas that our local voluntary sector play a very large part in. And I'm not entirely convinced that their views and experiences are always taken into account when transformation plans are made. I'm sure they can speak for themselves. And at 3.2 on the agenda there on page 178, those 5 principles are absolutely critical. I don't think anyone around the table would have any disagreement with them. The issue that I've got is that I've seen those for about 2 decades, and we haven't actually, as far as I'm concerned, managed collectively, and we've all got to take responsibility, to come to a point where we can say that, you know, we've got a very secure way of delivering those things. And on the issue of 67 people ready for discharge, a problem that obviously we know our acute hospital experiences, our adult social care sector is extremely challenged, and I think we have to think collectively about how are we going to build, and that may be physically build, facilities and services that allow our community to cope with some of the people who need to come out of the long stay beds and a hospital setting. Because what I don't want to have, and I have seen this in some of the requests that we've had for help and transfer with patients, a sort of situation where we find a community setting, recreate lots of the elements of what's happening to those patients when they're in hospital without the therapeutic support. I will, say now that I'm nervous about that, and I think collectively we've got to think about how we use estate, how we think about estate of the future, and, for things mentioned in here which are welcome, like a crisis house. We did used to have one. It shut down. Now it's going to open up again. That is welcome. The same with the recovery house. I've long heard that they are, on a sort of world scale, the sort of best paradigm of facilities that you can offer, but we haven't yet got to a place where they are securely available to people in Medway and indeed to the rest of Kent. So just a couple of comments there, but I'll go to questions. Eddie, you had a question. And can I just ask you, Eddie, please, to be mindful of, not confusing not confusing, but not merging elements of your own work absolutely with your own experiences are really valid as a practitioner, but just for your interest protection and the protection of the board, just to be careful about that, please.
I'll rephrase it then. I am aware of there being a problem with recruitment and retention in the mental health. For good reasons why I'm aware of this. I was wondering how that is improved. It's reckoned to be one of the most stressful jobs there is, with a very high turnover. And no, so if I start to say more, it'll be personal again. So I'm just wondering how you address that, because I know that KCC as well as Medway has really struggled, and that experience that's accumulated and then lost is a great loss, because mental health is an arena in itself. So I was just wondering how you're dealing with that. The other thing is about placements. So you've got the amount of people in beds needing to leave down, which is really, really good news, because I can't say I'm aware of, without going into detail, of this issue about, because I've been there in casework, where there is somebody who has been diagnosed as being suitable to go back into the community, but there's nowhere for them to go. And a lot of the options that used to exist literally have not been resourced during the past decade or so. And there is a consequence to that, and that's why I emphasize it. If it's not funded, it gets lost. They literally don't exist anymore. You have somebody who's occupying a bed that could be so much more healthy if they're back in the community, but there's nowhere to go. So I don't know if you've got any light to shed on that, please. Thank you.
Adrian, and I'll come to Caroline.
Hi, thank you. I just wanted to pick up two things. I know that my GP colleagues, they feedback regularly that we still are experiencing referrals being rejected. And so the no wrong door approach and the investment into the community mental health framework I appreciate is to try and bridge that gap, because we have services, the IAP services quite often can't meet the needs of our patients, so we refer, but they might not meet the threshold of KMPT, and there is this grey area. But I just think, obviously that a lot is changing very quickly, so just a plea to make sure that everyone is communicated with, so that's patients and our GP primary care colleagues. The second point was just something you mentioned. You have 250 beds across Kent and Medway for acute inpatients. How does that compare to the rest of the country? So in Kent and Medway, do we have equivalent numbers of inpatient beds to the rest of England? Thank you.
To you, Adrian, please.
Thank you. So in regards to the staffing, we have seen a number of initiatives underway in the last 12 to 24 months, not just things like overseas recruitment for our acute beds, but a number of initiatives looking at those enhanced roles that Ash was talking about, and those combination roles as well, to make mental health more attractive for people to come into and to remain. We've also seen the expansion of other allied professions such as social work and social work apprenticeship type roles coming into the organisation and then growing from that. We started last year with a vacancy rate for Medway in around June, about 20%. That's reduced now down to about 14% across KMPT through initiatives, and our turnover rate remains lower than national. And in fact, the turnover rate was one of our ambitions to reduce, and we are at 6 months in the green for that. So we've made some really good inroads in terms of that. In terms of the blockers to discharge, sometimes it is social care, and we work very closely with social care on that. But we are finding now that actually, in terms of that, it's not around just packages of care and things like that. It's actually we have a large proportion of them who are actually homeless as well, and we're already needing to have the conversations, and the board can help with that, with regards to having that threshold of risk changing with regards to do we discharge to temporary accommodation and things like that, because otherwise we're not going to find housing for all those patients. So there's an ask there. Absolute take your point in terms of communicating as well, and we do have across Kent and Medway one of the lowest bed stocks per 100,000 residents. Compared to national. Just looking at my stats here, we have for younger adults 15 beds per 100,000 residents population against the national mean of 23, and for older adults that's 23 beds per 100,000 population against the national mean of 43. So we do manage those beds very tightly. We also find that actually our 30-day readmission rate is lower at 6% compared to the 9% national average as well.
Caroline, so I don't think we quite covered there the rejection of referrals, did we?
Yeah. But also just about the bed stock. So why is that? And is there a plan to increase it? Because it's the patients who are waiting to come in that I personally, as a GP, have them coming back and talking to me. And the rejection of the referrals. So can I tell my GP colleagues that patients are going to find their way to where they need to be. Thanks.
So I'm going to answer that first, and I think Andy might want to come in with regards to sort of the bed stock as well. So with regards to the rejection referrals, I really don't like the word rejection because I think it's just not right, and it's not the right way we should be looking at it. I think there's a lot of work in terms of the community mental health framework about how we address where they should be going as well. And quite frankly, it's about what you mentioned, just a minute ago with regards to communication and how we have that that two-way dialogue with primary care about this referral may not be best suited to come to KMPT. It might be better somewhere else, and that's about building those relationships. And I acknowledge that we've got a long way to go with regards to that, but we certainly are working. We are certainly making inroads into that. We're also slightly increasing our bed stock from next month when we open our new Ruby ward. We increase our beds from 10 beds to 16 beds for the population, so it's a slight increase. I'll pause, and I think Andy wants to add something to that as well.
Thanks, Adrian. Andy Oldfield, Director of Adult Mental Health for Kent and Medway. Just to come back on your question about bed stock. As it says in our paper, we've very much been dictated by the Mental Health Long-Term Plan for the last 10 or 12 years, and that's very much been directed at more care in the community, less care in hospital. So you will see across Kent and Medway, as well as other parts of most other parts of the country, where bed stock has been reduced, in some places quite dramatically. There is a view we have enough acute inpatient beds to manage our demand for people who need acute inpatient beds. However, as Adrian's already alluded to, a number of those beds have people in them who have complex needs but don't need to be in an acute hospital bed, and it's the lack of appropriate accommodation for those people, for a combination of reasons, is causing this issue.
Okay. Thank you. I've got Simon, then James, please, then Jackie.
Yeah, thanks, Julia. Thanks very much for your report. It's really fascinating. I might be sort of showing some ignorance here because I'm fairly new to this board, and obviously this is an area that I'm not completely familiar with. I've got a couple of points I'd like to raise. One is in relation to your on page 177 at the start, you talk about the partners we work with, and I think that's really important that obviously Medway Council is a key partner in all this, and that's why we're here today. And in relation to that, you talk about recruitment and retention, and I'm just wondering why the solutions for this sound like they're very similar to the solutions that the GPs have come up with, and whether or not is that the kind of model that you're looking for your own staff, and recruitment and retention of people is similar to what the GPs are now achieving. I mean, if their numbers are going up, it's because of the work they've been doing. We need to do something very similar along those lines, and what partners will be needed to achieve that is quite an important question on that one, I think. Coming into a different areas, I'm jumping around a bit, do apologise for this, is about on the last of that, on paragraph 2.2, you talk about patient flow through the organisation. Presumably that at some point people are then moving back into the community. I mean, that's what you're implying there. And then on the jumping down a bit further, it says care takes place in the community. Is there any definition as to which community we're talking about? Because there are so many cases now, and I've got them in my own ward and that thing, where the people actually coming out of care and back into the community aren't coming out of Medway care, they're coming out of London care or somewhere else care and ending up in Medway. And although they are being cared for, and the companies, the private companies, from what I gather, who are looking after them in the community are doing a good job in general. That's a very expensive approach to care. And also, when the crises come, which they do on a regular basis, it's our services that need to respond. And I'm just wondering about how that dynamic works. And I'm not sure if this is the appropriate time to raise this or not. Teresa's nodding. But it is an issue that I get quite regularly comments from. So that's one issue about that and how we deal with that. Because obviously we've got our own pressures here in Medway. And then if people are being referred from London down, because the house or the houses where people are being moved into have been bought up by London providers, that's a problem. And I don't know what the solution is. I'm just raising it as an issue, if you like. And then the third issue, which is kind of where I'm not completely clear, but it's obviously in there, is the issue around dementia. Presumably, initial dementia diagnosis comes through your GP, but at some point then it gets referred into mental health issues. And I'd assumed, and I think a lot of people do, that dementia is actually a physical problem primarily related to the way your brain is is working and your age and stuff like that. So why is it now moving into mental health? Is a question there. Thank you.
I'm going to ask James to come in and Jackie, and then if you can come back. And Eddie, I have seen you coming back with the second point after the ones I've just mentioned, please.
Thanks, Chair. And just a quick one, Adrian, and thank you for recognising the prevalence of smoking within that population, also the SMI health checks, because I know you've got 30% prevalence for Medway. Remember, our standard prevalence for adults 18 plus is 8.9%, so that's a significant difference. So we you know, being supportive, we have got additional resource, and Scott may talk to this a little bit later on, but we want to put an enhanced focus on mental health and in particularly workforce, because that's an additional challenge that we know that you need a little bit of support with. So hopefully out of this meeting, clearly, I know you're in the tobacco dependency group, but I just want to give you that assurance that we are doing additional work hand in glove with you to deal with that challenge. And then the other bit really is just around the potential collaboration around the Work Well programme, because of course many of the people that will be out of work, and we know this, I was on a seminar last week actually with the Society of Occupational Health Medicine, and in particular women have got mental health challenges, which is preventing them from being within the workplace. So hopefully Kent and Medway are one of the hopefully there's 35 organisations. We'll find out on the 4th of April whether we're successful in that, but there'll be a particular role, I suspect, and I see Vincent, who is clearly steering a lot of this for the trust to help us with supporting some of those people alongside primary care, of course. So just two things just to flag in that.
Thank you. Jackie?
Thank you. I just want to sort of reflect on the problems with the flow, so being able to discharge people from hospital, and we talk about it regularly, the challenges in the care sector. I think, you know, one of the things that we struggle with from an adult social care point of view is generally when people are younger as well. So people that might need to go into supported living, and Councillor Murray's mentioned that sometimes social care providers feel that they're being left with risk because of the people's complex needs. So that need to work together closely to make sure there's that wraparound support, which then means that the care providers don't feel that everything's on their shoulders, is really, really important. So I'm really keen that we look at that. I think then the other element for me is about, I think Martin's at the end of the table there, but we were having a conversation this morning about at what point do you start discharge planning? And one of the, and we've got one at the moment, I'm getting emails regularly about it, where we've got somebody that should be coming out of a hospital, but they can't because they are homeless. Now, if we'd have known at the very beginning of the process that that person was going to be homeless, we could have started to work with our providers, you know, the housing team early on. So I think that point of contact of starting that piece of work at the beginning is really important. And I don't know if you do that already, but I just wanted to flag that.
Eddie, just a quick last question then, because I'm conscious of time, and for everybody on the board, we're going to overrun a bit if that's okay with everyone, but I think it's worth doing because we've got some important items to take. We were due to finish at 4. We're not going to. So I'll just put that out there. Thank you.
Okay, I'm just thinking about how to scale down what I was going to say. Can I just say that I'm grateful that you recognise about suitability of accommodation? I think there's a lot of people who don't understand somebody's been diagnosed to go back in the community, they have capacity, so what is the problem? But a large number of these people will never ever stop being very vulnerable. And it's not the same as a physical condition which gets fixed. These people will always need support in the community, and therefore it is an amazing challenge. I did want to ask about you've got good retention figures. Does this relate to the support that your staff have? Because I am aware that one of the complaints was about support from the management structure. This is not saying managers are nasty people. This is saying the management structure is not able to give the support that they need. And a lot of people leave this environment, it's got actually nothing to do with pay. It's just about how they feel and they're being treated. That's the question. Thank you.
Thank you. Okay, Adrian.
So I think I've got most of these questions. So in terms of partners, I think it's key for us over the next year to concentrate on partners that are going to help deliver our 6 priorities, and obviously Medway is one of them, and will continue to be one of them. And we are finalising, how we work with those individual partners to help us with our 6 priorities. The recruitment and retention piece was similar to what we heard about primary care and GPs. Our chief people officer sits alongside all the other CPOs. And with the ICB as well on looking at some of those initiatives, and we do learn from them, and we do share what works. Some of them aren't suitable for hospital or for secondary care compared to primary care, but we do continue to look at all of that. We mentioned about patients moving out of London into Kent and Medway. Some of the community mental health framework will hopefully pick up on some of that. We do recognise that transitions in general is a significant area that we have to concentrate on. For example, children transitioning from child and adolescent services into working adults, which is currently from a different provider. We've actually introduced alongside our colleagues in the ICB a transition team to help with things like that. Now, that's only for children and young people, but I think that's really good working practice that we could look at in other things as well, and we can pick up in the CMHF. In terms of dementia, we are one of the largest diagnosers of dementia in Kent and Medway. We are working alongside our colleagues in primary care to try and help with GPs with enhanced roles to help with that as well. But there is also now, in terms of the transformation, I'm the exec sponsor for it at KMPT, looking at how we significantly change our model for diagnosing. It is unacceptable that our patients are waiting so long for a diagnosis, and we are setting out in the next 3 years to hopefully have 95% of our patients diagnosed within 6 weeks, so they can then tap into the services. Now, we can't do that alone. We have to do that in collaboration with other services and other providers, and including the VCSE sector as well. The Work Well programme, James, absolutely. We're aware of that. And we're fully supported in terms of that, and we're more than happy to look at where that will fit in. With regards to the discharge planning piece, absolutely. In my eyes, discharge planning starts the moment a patient needs to come into a hospital bed. Now, that is a piece of cultural change for the entire healthcare industry, and we are working on that. And that will go alongside some of our cultural change programs that we've referred to in the document as well. And with regards to our staff feeling empowered, we're launching in terms of our cultural change and our improvement program over the course of this year. We want staff to feel empowered to be able to make changes, and that's why they want to come to work. And we see more of that over the course of the next 18 to 24 months.
Thank you. And before I come to you, Vincent, I'm really pleased to hear that you've mentioned the forthcoming plans for children's mental health. We had a very good presentation from Suzanne at the ICB last Thursday, and it did occur to me then that there are things to be learned for adult mental health. In particular, actually, the idea that there's going to be a 13-year commitment, sort of 10 plus 3, to the contracts, which I think has got the potential to create a lot of stability, and the model that's being promulgated there in children's for that sort of therapeutic alliance, so the bit between diagnosis and before people actually get into a clinical environment, taking advantage of everything that's in the VCS and so on, and a real push to help people understand that I think, as some people have already said today, it isn't always necessary to have a jump straight into a medicalised clinical environment when a mental health problem is diagnosed, and getting not just the transition from one authority to another, but the transition for young people to adulthood, I think has to be an absolute priority and something that collectively we need to keep an eye on here. So Vincent, please.
Thank you, Councillor Murray. I'm Vincent Bidou. I'm the Chief Strategy Officer in the ICB, and I just really wanted to make the connection to one of the things you set out at the beginning of this meeting around how we can work together as a Health and Wellbeing Board to support our population, and particularly in light of the points we've just heard from Adrian and Andy around mental health, but also from Suk and Ash around physical health, and there is a connection between the two. So I really would encourage us to think about where there are opportunities for us to work differently, thinking about the changing nature of the population in Kent and Medway as well. We are going to see in the future a growing number of people who are older and over the age of 70 who will need support from our services. So although I recognise that we touched on dementia diagnosis, and at this point KMPT is one of the only organisations that provides support for dementia diagnosis, but actually with an increasingly older population, we'll need to change our model so that actually people can access those services in a different way, in the same way that Ash and colleagues have described, we need to access primary care in a different way. So again, I'm just linking that to the work that we're doing together around the integrated care strategy, which is really about driving us to think about our population across those shared outcomes so that we work around that. And I'm really putting that as a bridge, because I think one of the things we have to do differently in the NHS is start to think beyond just the boundaries of individual organisations to how we work together as a health system and a health and care system. And again, that's one of the big challenges for us about how we will make decisions in the future about where we locate resource, but also how we ensure that the population can access that resource in a timely way, but also where we support the population to move out of those secondary care services, perhaps into primary care services, and then into community services. And so it's really important that we start to recognise the boundary of what a secondary care service like Kent and Medway Partnership Trust can provide and what we could do differently in the community. And I think that's a real opportunity for us as a Health and Wellbeing Board to influence and inform some of that as we go forward. So I'm really keen to think with yourself and James and others about how we bring some of that into the agenda for the Health and Wellbeing Board as we go forward.
Thank you, Vincent. I don't know if you want to comment, James, but that really ought to be very clearly defined in our priorities for the health and wellbeing strategy, didn't it? And we perhaps need to, in the light of what's been said and from friends at KMPT today, just review and refresh to make sure that it encapsulates. I know it is in one of our priorities, David and Charlie, and we'll come to that in a minute, but I think that's a critical thing that you've raised there, Vincent. Okay, if there are no more comments, one thing that we didn't touch on today with Jane here is in fact that of all places who are recipients of people who can't quite find their way through mental health services, I'm afraid the hospital is one of them. And indeed, just lately, you've been finding that more people are turning up there. And I think collectively we do really need, the safe havens are great, but you know, need to make sure that practitioners across the piece understand that A&E is not a good place for a person, an adult or a child, to find themselves if they're in a crisis. And Jane's got her share of beds, and we in fact, at the Council of Governors, we picked up this point about homelessness being one of the biggest causes of no right to reside. And I think there's a responsibility for us as a council to consider what we do about that. And actually, I think in the longer term, consider structurally within the council where we think some of the supported housing and specialist temporary accommodation needs to go. So just for your comfort, you know, we're very aware that I think is a growing problem, and not everybody that's homeless in your facilities or Jane's come from Medway at all. So there's a Kent-wide sort of responsibility that we need to exercise there. So thank you, Jane. If I go to you, please.
I'll try and summarise it. So the Health and Wellbeing Board is asked to note the report and to consider how they or the organisations that they represent can help deliver KMPT's priorities, including opportunities that enhance collaboration and partnership working, the use of estate, referral management, and flow and discharge.
So with that. Is that agreed, please? Okay, thank you. I'll go to the next item then, which is adult mental health in Medway. And welcome to Charlie Satow, who I think one of our public health registrars is going to work with you, David, to introduce this item. Sorry, that was the wrong one.
That's Andy's.
That's Andy's, I beg your pardon. Sorry about that. You're doing the... Sorry, Charlie. Frightening you to death there. Yeah, thank you, Andy. Yes, okay. Yeah.
There you go. Thank you. Thank you, Councillor Murray. I'm aware of the time, and I would very much like to ask the board to consider this paper in conjunction with the KMPT report, because we're talking about an overall pathway of which the CMH transformation is probably by far and away the largest part. And to a great extent, we're talking about the same cohort of people who use mental health services. It just depends where they happen to be on that pathway at any given moment in time. So the report you have here is very much focused on mental health urgent emergency care, and as it impacts, if you like, on our acute trust colleagues and the transformation developments we're putting in place to support people that find themselves in mental health crisis. So you have you've got information on the adult developments. My colleague Hannah's here to take any questions you might have around the children and young people's mental health information you've got there. And also in the paper, we've got contributions from our public health colleagues at the end about some work that they're doing. I did mention very briefly that mental health commissioning has traditionally, at least for the last 10, 12 years, been very much focused on the mental health long-term plan, which is nationally mandated. So largely, they're the areas that we need to focus on. And whilst we try to flex and be as responsive to local need as we can, predominantly the funding that's is provided and the areas that we're monitored on are set nationally, and that's been the same for some time. So what you have here is some detail around children and young people's mental health. Lots of areas around the mental health urgent emergency care pathway that we're developing and working on at the moment around NHS 111 Select 2, the safe haven developments which we've already heard about, the crisis house development, and then there's issues around mental health conveyance service, an update on the Section 136 centralised work that's happening there, urgent response, and there's also detail about the Right Care, Right Person programme, which is being led by Kent Police, of which I'm sure you will be aware of. Whilst that is predominantly seen as a mental health programme, it actually touches on the much wider health and social care system. So it's really important that everybody understands the implications of that moving forward. And we also touch, following on from Adrian's paper, around physical health of SMI, because whilst KMPT completely adopt the approach about looking after people's physical health for the people that they're in contact with, large numbers of people with severe and enduring mental illness are in primary care. So it's a primary care responsibility to take this forward as well. And as I say, there's some detail there from our public health colleagues around the work they're doing. So unless there's anything you wanted to add to that, Hannah.
Is this on? Oh, yes, hello. No, I think Councillor Murray had mentioned earlier just the work that we're doing in the space for children and young people in regards to mental health and emotional wellbeing, which is our re-procurement of all of our services for mental health and emotional wellbeing across Kent and Medway for our young people's population. And I think that was the biggest thing in the appendix and report that I'd written. So just if there was any questions on that, otherwise that's it. Thank you.
Okay, before I come to questions, I mean, thank you for this. And I think some of the graphics and charts that you've got at the end about the right place to go to, particularly in this case, referring to helping families find the right place to go to for children, are really important. And I think one of the things that is critical is to make this a navigable system, so that people who find themselves in a situation where they need mental health support know where to go. You know, I know we've got the single point of access. I know you've got no wrong door. We've already heard from Caroline where that actually can go wrong. And I have to say that I have got some concerns about the right care, right person. The police were invited today. They were unable to send someone. I've had 2 meetings myself with Tracy Harmon. And whilst I understand where the police are coming from, in the sense that they, feel they are inappropriately called to mental health crises and various things, the tenor of that strategy is to push away from the police and onto other services where I'm not sure the capacity currently exists. And I did also have the opportunity to raise this at the Police and Crime panel last week with the Police and Crime Commissioner, who is running a sort of line that, we ought to be grateful it wasn't just thrown on to us like the Met did, and we've had a period of run-in before the implementation in April. The question I asked was, well, wouldn't it have been better perhaps to pilot this in some areas so that we could find, where the loopholes were, where things were not working? His answer was that he felt that would just mean that the service was inconsistent, which is not an answer I accepted very readily, I'm afraid, because actually when it suits the police, they do all sorts of pilots. I just raise that as a concern, and I'd be interested to hear what other people think about that. But, there is some really good practice ideas emerging. I just want them to be as successful as they can. And back to your point, Vincent, in the previous item, the kind of collective will and resource allocation that we can put to this is really important, because the problems being raised are persistent. Telling my story over and over again, having to start from zero if I have another crisis, not being able to find the right place for me to maintain my healthy mental state when I'm well again. I think all of these things, we've been round and round the loop with. So, the more that we can come forward to actually push this on, the better. So Hazel, then Simon. Anyone else? Okay.
My first one is about complete ignorance. I'd like to know what the conveyance in service actually is. My second question is back to what you were talking about, the right care, right person. Teresa, as I understood it, the crisis house here in Medway, it was put in place for the police to avoid Section 136s where possible, which nobody disagrees with. But my worry was that if what's written down here is that the healthcare providers are required to address, the transport between the police station and somewhere else, then who's doing it and when's it picked up? I think the ICB may have an answer to that, but the provider at the receiving end is a provider at the receiving end. They're not a transport company, and I do worry about this being left to, maybe even to our licensed vehicle sector. So I'd just like to have a little bit of detail on that. Thanks.
Thank you. I'll ask Eddie to give your question, please, and then come back to you, Andy.
I could respond to Hazel.
Yeah, thanks, Teresa. Thanks for the report. I've got, again, I think we're seeing the synergy between several of the items here on this agenda, which is obviously inevitable because of the kind of work that you all do. And I think so I just started to kick off with, in paragraph 4.4, you talk about the role of the groups like Men in Sheds and stuff like that. And that's going to come in when we get to the last item about the crowd issues and everything, which is quite exciting. But I just wanted to highlight a really good news story there. If you want a bug house built, Men in Sheds are your people to go to. They are brilliant. For our parks and green spaces across Medway, they are now filling up with bug houses built by them. So I would recommend it, if you want one for your garden, get in touch with them. And they don't charge either, which is nice. So I just mentioned that, how important that is. I mean, that kind of work is vitally important. I just wanted to move on to page 201 in the report itself. and talking about the waiters that you've got, that list of number of waiters dropping down from November 22 all the way down to November 23. And yet the data, I'm not quite sure how I read the data, because things like suicide, self-harm are increasing, and so there's an issue around there about who's... Oh, is my microphone on? Oh, sorry. Going in the report, that is on page 201 of the report, is the number of waiters falling down. There's a graph showing there. And then, but going back up through the data on referrals of things like that, it seems to be that there's numbers are increasing, but the waiters. So I'd just like some clarity around how that data sort of fits together. You also mentioned in terms of ADHD referrals on page 199. There's a box there which talks about the ADHD actually coming down, but with a 3-month waiting list to be diagnosed does seem an awfully long time as well. So just why that is and explanation around there. And also in relation to that point, you talk about ADHD in relation to young people over 11. And actually the worst I see, certainly in my own primary school where I'm a governor, is the under 11s. I mean, that is, and I'd like to know if you've got some information on the under 11s on the ADHD. And then the final point on this is in relation to the universities. I mean, there's a sad case we just heard about in the press for a number of months now about a young person committing suicide in universities. We've got an increasing student population here, and under the emergency care part of the work within the report, and the role, because obviously students at university are effectively adults. The universities, their role is not there to be their parent, but there to be their educators. And that dynamic between the universities and the students and the emergency care for mental health that we provide, how does that work in Medway? Thank you.
Okay, over to you, Andy, please.
Yes, thank you for that. If I pick up the first couple of points, which I think is relating to the adult mental health conveyancing and crisis response, and then I'll hand over to Hannah for the other points that you raised, if that's okay. So in terms of conveyance, we are in the process now of commissioning a bespoke conveyance service. So we will have mental health practitioners working specifically to supply a service that will convey people from where they may be and where they need to be. Where police have previously taken a role in that, they will be stepping back, as we've heard, and we're aware of that gap, and we're commissioning specifically a service to fill that gap, and we're working on that now. In terms of crisis houses, there's a number of initiatives on here which are aimed, when you look at them in around, to support people who are in mental health crisis. Now, I don't think anybody disagrees that really not the best place for somebody in a mental health crisis is an acute hospital emergency department. It's not right for them, and it's not right for the emergency department either. It really isn't the right place. So everything we've reported here is our work to try and provide alternatives. And we're really pleased that we're able to take a number of these initiatives forward. And they're coming in, some as we speak, and some very soon.
Thank you. So the data that you see in the report for the children and young people's mental health is in relation to the waiting times from assessment from referral to treatment. So there's two parts there. We are seeing an increase of referrals into our Medway Young Persons Wellbeing Service, which provides that particular service. The assessments are being done for the initial assessment within sort of a 3 to 4 month period, which pre-COVID we were looking at probably over 12 months for an assessment. And then in COVID, some difficulties with an increase in referrals. And then just as we started sort of the last sort of 18 months, we've started to see the numbers improve. And so that's kind of the referral period for sort of a generic mental health assessment. In terms of the ADHD, that used to sit across Kent and Medway, and under NELF, who provides the Neurodevelopmental Learning Disability Service. And we have incredibly large waits for our neurodevelopmental assessments, which is a national issue in terms of the amount of referrals that are increasing and coming into the service, and then obviously on top of that, workforce issues. But what Medway Young Persons Wellbeing Service have done is they've actually taken the ADHD element of that service and they've brought it in-house into their mental health team. And so actually we've now seen an improvement on the waiting time. So that 3 to 4 months for that assessment is a huge improvement from what it was about 18 months ago. And generally, mental health services that are commissioned will have sort of key performance indicators, and they're roughly around an 18-week period. So we would say that those numbers not only have improved, but are also sitting within that key performance indicator of well below 18 weeks. So I think one of the graphs that you had up, it showed the sort of decline, but the improvement of the number of children waiting for treatment. So I think it was 170 something at the sort of a year or over. And so that shows the number of children that are now waiting over 18 weeks, which has come right down. The under 11s, yes. So the data that I've provided and information is because I commissioned the service which now provide for the over 11s, for the neurodevelopmental, which is predominantly ADHD and ASD. But my colleague, Julia Cox, in partnership commissioning, she commissions the under 11s, and that sits with Medway Community Healthcare. So I would be able to get sort of figures and data if anybody needed that. I don't have that on me today, but absolutely there's a pathway that goes across sort of all age. So under 11s for MCH and over 11s for NELFT. Thank you.
Sorry, Simon. Oh, yes, please.
So to pick up that question, we're, as commissioners, we're actively looking at whether there's an opportunity to provide specific services for the universities here. The example is Canterbury, where we've had an established mental health service for students at Kent University for some time, and we're looking at, and that service also reaches out to Christchurch University in Canterbury, but we're looking at being able to provide, a similar type of service in the Medway area for the campus here.
Okay, so if there are no more questions, thank you very much for that, Andy. I think there's some really exciting initiatives there that are planned, and I'm sure we'll be returning to them, both through our work with HASC and more generally feeding back to you as partners. But it's good to know that there's a focus on needs, and I'm especially pleased from both of the reports that there's a lived experience position now that's really drawing on how the mental health community respond to services and the way that they feel things are actually working towards their needs. So that's good news. Okay, Jane, please.
Thanks, Chair. The Health and Wellbeing Board is asked to note the contents of the report, and I think with a specific action to work together regarding the right care, right person.
Yeah, thank you very much. Is that agreed, everybody?
Agreed.
Okay, and now then back to you, Charlie, for our joint health and wellbeing strategy. So it's nice to welcome you to the board and to your work as a public health registrar, and I'll leave it to you to lead us in.
Thank you, Chair. So my name's Charlie Sato. I'm a specialty registrar in public health, and I've been involved in drafting the strategy under the guidance of the Deputy Director of Public Health. So just by way of introduction, framing, formally upper tier local authorities and integrated care boards are required to develop a joint local health and wellbeing strategy for their area. This is the strategy for the Health and Wellbeing Board and drives its work. The strategy is framed around 4 key themes: healthier, longer lives for everyone, reduce poverty and inequality, safe, connected and sustainable places, and connected communities and cohesive services. Compared to the previous strategy, there's a stronger emphasis on the building blocks of health, such as housing, education, employment, and the environment, and it stresses the importance of working collectively to improve health and well-being, which is a key theme we've heard about throughout the items today. The board reviewed an earlier draft of the strategy in September and again in November. Specific comments were provided, and these have been incorporated into the drafting of the final strategy, which has gone on in parallel to the drafting of the integrated care strategy. Achieving the strategy will require members of the Health and Wellbeing Board to translate it into action within their respective organisations, building on the extensive work that is already going on across the system and identifying what needs to change. And finally, we're developing a logical framework with appropriate indicators to track progress against the strategy. Back to you.
Thank you very much, Charlie. And for myself, I'm particularly pleased to see the graphic on page 6 that talks about the building blocks of health and reminds us that all of those things, which also, of course, chime with our work on the wider determinants of health in the research collaboration, how all of those things coming together lead to a healthy life. And I think it's important for us to be very focused on all of those. So it's taken some time to get the final draft, but I think that was time well spent because we've had a lot of real-time consultation. And I do thank the teams under your direction, David, for going back to the strategy and bringing in the things that have come up as we've gone through the consultation. So I think it's in a good place now. And obviously, Vincent, this sits, directly underneath the ICB's overall strategy and is a place-based encapsulation of the things that we want to happen for Medway. So with that, I'll go to any questions or comments, please. I'll go to Councillor Hackwell first, then I'll come to you, James, and then to you, Simon.
Thank you, Chair. I also like the infographic. I'm a fan of infographics. I think they can tell you quite a lot. However, I was disappointed that we've got a figure out there on that infographic that's 8 years old, 2017 numbers. I mean, if we're putting something out in 2024, I would have thought that we'd have had better numbers than 2017. So is it possible to get that updated before it goes forward? And also, I had trouble in the bottom of that, when we're talking about the gap in life expectancy, about distinguishing which one was meant to be representing the more well-off and the less well-off, because the coins were exactly the same. So for clarity, I wonder before it gets published whether we could do some little bits of tweak on that infographic.
Thank you, Councillor Hackwell. James, please.
Thanks, Chair. And it may well be, we'll have a look at that. You're looking at the 2017 data on the people who live in mental health. Okay, so that might be the data set, and David might be able to reflect on that, but clearly we can update that if that, because it's a draft. My points really were just around, this is our play-shaping document, and back to Vincent's comments earlier about being able to do things differently and also talk about the physical and mental well-being of our population. This is how we set out that vision, and hopefully we'll be able to deliver against that through, as we've mentioned before, making sure that we pick up the cross-cutting themes between what we're doing here at place level to what needs to be done at a system level. And actually, when we start to break down some of those challenges, and it's just unfortunate the two colleagues from our Mental Health Trust have left us, but there's quite a lot of work in this document that tries to pick out the inequality element for people with an unfortunate lived experience around mental health and challenges. But Councillor Hackwell, we'll look at that data, but I'm pretty sure we'll be able to rectify that with a quick tweak. But
Okay, David, do you want to come back on that? Or
yes, just briefly say that the intelligence team checked all of the data, and that's the latest published figure for that particular measure.
Okay, well, perhaps that's something, as James just said, our mental health colleagues are not here, but that's something to perhaps pick up with them in terms of currency, although I do think the data still reflects the place that we're in, Councillor Hackwell, but you're right to raise it. Any comments from anybody else on this strategy? I think it's Simon, before I come to you, because you've had a welcome lots of goes. So anybody else who hasn't spoken before I come back to lovely Councillor Curry? Vincent, I'll call Vincent and come to you, Simon, for the end there.
Thank you, Chair. Mine's a very brief comment just to really welcome the document, but just to also say one of the things that we've been grappling with is how we in the NHS align to local place-based improvement plans as well. And so I really wanted to just highlight that we're going to take a different approach this year. We now have an integrated care strategy. Colleagues will recall that last year we were asked in the NHS to develop a joint forward plan, which reflected the things we would do. That was uncomfortable for us because actually we recognise we're part of a wider system. And so this year we've agreed together that we will develop a shared delivery plan that will enable us to absolutely support the local place-based focus, but also be really clear about what we will do to contribute to the wider system as an NHS family, if I can describe it in that way. And so we will be coming to the Health and Wellbeing Board to carry out the consultation around development of that plan, but also presenting that plan back. So really just to say that, you know, I will continue to work with James and David and other colleagues around the room to make sure that actually we can interface what we're doing in health to also support what we're doing across the wider system for the Medway population.
Thank you, Vincent. If we can do that on a workshop basis, I think that would be helpful. So I'm sure that we can work with Stephanie and James to sort that out. Simon, please.
Yeah, thanks, Teresa. I'll be brief. Apologies for diving in, but this particular report is very exciting, actually. I'm really pleased that it's come forward in this way. I mean, I love a good QR code and things like that as well, which takes us to even more information. And just reflecting on it, page 224 of the overall report, page 6 of the document, I think kind of sums up where we are with that, with the building blocks of health. And if you look at the local plan that we're producing, they're almost identical. And then if you look at the Medway plan, it's almost identical. And this is where the links and the connections and the partnerships are created. So it's very exciting to see all that. I won't say too much more because I think I'm sort of echoing the views of the room really in many respects. One thing I would like to just emphasise, and I'm sure this sits behind it, which is fantastic, and I know it does, is about the risk and the risk strategy that lies behind that. In order to get this to work, we need to be clear about where the risks are. Climate gets a mention, and just doing risk reviews of climate at the moment as we go into sort of more severe weather and that sort of thing, it has direct impact on communities. Heat is a particular problem in the summer with people's health, particularly the elderly. I mean, just 2 years ago, we had over 40 degrees heat in the middle of Chatham, and that caused serious health problems for people. So there is issues around risk management behind this, but I'm sure it's there. Thank you.
Before I come to David and Charlie to answer that, and Sam, you've raised a really important point there, and I think this accords with our workplace strategy of public health as well, because at the moment there is only health and safety legislation about cold. There's no actual legislation about heat, but it can be, you know, have a very deleterious effect on people's ability to work productively and to stay well. And I think it's particularly important for certain groups of people, such as menopausal women, for example. So, you know, I think increasingly we're seeing across the piece that these strategies have to work for our people, our place and our planet as well, that you know, and to do that in concert with one another. So that's a really important point that you've raised, Simon, and I think it, as you say, it is exciting and it is welcome to see that the, you know, different parts of our joint work, the local plan, that this work are coming together, and we're thinking of one accord. Now that does not mean we can just have one great big giant plan that, you know, encapsulates everything, but it is important that our priorities are shared, and that the delivery through the various work and mechanisms of the Council and of the ICB, the ICP, do actually work together and not against each other, which I think, you know, has not always been the case. So that's a good thing. Anyone else coming back on that? Okay. We'll go to you, Jane, please.
Thank you. The board are asked to provide their support for the joint local health and wellbeing strategy and consider how they can help to deliver on the key themes through their roles within the Health and Wellbeing Board.
Thank you. And I think we've identified there that working together on those shared priorities with what Vincent has just said as well is able to make that happen, and that, you know, we're not going to be constrained by coming back and looking again if we find that something isn't working. So thank you, Jane. With that, is that agreed, please? Right, we're coming further down the agenda, thank you, to The Power of the Crowd, a great title, actually, for our annual public health report, and a very sincere one from James and I in our forwards. We do believe in the power of the crowd, and there's lots of examples in here of the way that working with our local community, whose enthusiasm and commitment has been tremendous, actually, from lots of the organisations in your sector, Jane, and actually even from individuals taking a very grassroots approach to making some of this stuff happen. So with that, James, I'll pass over to you.
Thanks, Sharon. Colleagues, I'm mindful of the time, so rather than me go through page by page, because I'm sure that you'd want me to do that, I'll try and summarise. So we've talked quite a lot in this meeting today about connections, and actually we've talked about our population, and what this report is set out to do, and hopefully it does, is give you a flavour of the ability of our people, that's local people in Medway clearly, but it could be anywhere, but we focus on this, to actually make the difference for themselves. If they're given the opportunity, if we're given the resources, and the resources isn't again just about financial stuff, it could be mentioned before about the training, the additional support that people might need to have. We talked about facilities, buildings, things like this. But ultimately, if we are able to invest more in building on people's capacity and capability, what we see is a sea change in the way in which they perceive the problem, and problems for themselves, that is, and the approaches that they use to address that. So there's a few examples within the report. Now, I mean, Ash is gone, but I think it's a really impactful one. So if we look at the hypertension stuff, we'll come back to that, because that was my report the year before. We identified the challenge, which was our disadvantaged and more ethnic minority communities were not able to access the support that was available. The support was there because they just didn't know how, or they weren't connected. So we worked with our local community groups, trained those up, and they then act as the interface. And you can see from the report in itself, across Kent and Medway, 180 strokes avoided and 120 heart attacks. That isn't just from that particular initiative, but that's from those local community groups working in partnership with colleagues in primary care, colleagues in the acute setting, colleagues in the community to advocate around hypertension, a significant saving, and also a financial saving over 5 years, £4.9 million. So these are real hard numbers. And for social care on its own, I'm sure Jackie and other colleagues in Kent will be clearly mindful of this, £1.6 million saved in avoided costs. And that's not me saying that, that's the National Clinical Director for Cardiovascular Disease who's come back to us and said, look at where we are. We've delivered, I think we talked about the A Better Medway brand, and the A Better Medway is our sort of interface with our community. Over 16,000 contacts in that period last year. 16,000, it's a significant number. Remember, people do not pay to access these services. Our obesity rates, I know I'm going to put Scott to shame now, but we were the fat man of the southeast and nationally, no longer, because we've delivered an intervention that's worked with our community, and they have responded through our Medway CAN approach, and that kind of community development, the same way in which we've engaged through our HDRC work and through the work that we did to develop our joint local health and wellbeing strategy. I'll pull no punches, because obesity and overweight is killing and will continue to kill our population early. It's something that we can avoid. So now our children and young people going into reception and leaving junior schools are now at the same rates of obesity as nationally, and we're going to do more, but our trajectory is going in the right direction. Again, why did that happen? It was through engaging with local community groups that people perhaps don't have contact, engage with our early years providers, our childminders, people who are working in nurseries, things like this, giving them an understanding as to what they could do to actually turn the tide down on that one. I've already touched on the loneliness issue around our mental health. Everyone hopefully is aware of our Medway Together pledges. I made a pledge and I've fulfilled again today. I've talked about 3 people going down to the shops and back again. It was really interesting. There was a chap by the pier. I said I wasn't going to go on, but I think this is impactful. There was a chap by the pier sat there with a bottle of beer at lunchtime. And I saw him when I walked past. I thought, right, I'll tag him when I come back. And I came back and I said, how are you doing? And he said, oh, I'm all right, you know. And he started to talk to me about the weather. And he started to engage with me about, you know, the sun and the seasonality and things like this. Now, I may or may not have been the only person that he's going to talk to today, but it sat on his own on one of the benches with a bottle of beer. So just by doing that and having that connection, maybe I've been another person that he might not have been able to talk to again. So it's just a simple thing, but creating engagement and opportunities and giving people the trust to go out there and just talk to people that they see are sat on their own and lonely is part of the work that we're doing around social isolation. But equally, I know Jane, with her voluntary sector community and our social prescribing work, is really at the vanguard of the stuff that we do there. And finally, I'm just going to touch on our Medway food partnership work. The inequalities that people face because of the cost of living, everyone has heard today that the squeeze is on, and it's on even further with our country going into, you know, a recession of sorts. People aren't listening to that, are they? They're just looking at what they can do week to week, day to day, to feed their families. And through our Medway Food Partnership and our infant feeding strategy, what we're doing there is trying to address the root causes as to why people might not be able to support themselves and give them the tools, which we have done, in order so to do that. So with that, Chair, my recommendations are set out. I won't read through them because I think colleagues will have had a chance to read them. But I do want to emphasise that when we go through that, we always talk about what we can't do. But if we look at what I've tried to do here, we can see what was possible, what is possible, and what we can actually then do to support further our population. There's also an addendum that sets out the recommendations from last year. I normally go through those and my recommendation around hypertension. Funnily enough, I don't really need to say so much about that, but I'll throw to Scott, because he will tell us how we're performing in relation to, because I know you're asleep, Scott, how well we're performing in relation to NHS health checks. Clearly, Scott, and the hypertension data for us, please.
Okay, Scott, thank you.
How quick I can press my buttons to give you the exact numbers, if that's okay. But yeah, from an NHS health check perspective, there's 3 markers on our public health outcomes framework indicators dashboards, and very pleased to say for actual attendances at health checks, we're second in the region in the South East. So that's a real sort of marked improvement, and it's been sustained over 3 years now. So just Slough to go, but we'll get there.
Thank you very much. And just for the board, on the food partnership, part of that, yes, Jane, I'll come to you, is the Food for Life project that works with schools. We've actually got space for 20 more schools to join that. So round the table, if you can encourage any schools that you're connected with, please, to get in touch with lovely Grace Dennis or just through public health generally. It's a fantastic project that gives free resources for schools to work with, activities, workshops, training for teachers, cookery with parents and children, all designed to get people to understand more about their food, where it comes from, how we grow it, how it feeds us, how it keeps us healthy. And we've got those spaces on the project. So it would be great to get more schools join, especially secondary schools, actually. You know, you can nominate anyone, use your contacts and your networks, and I think as an action from the meeting on all of us, I'd like to hear about that. Also want to mention that, you know, we do celebrate all these achievements. So we had our Better Medway Champions Day, and I was pleased to attend with all of the champions, hear about what they'd done and hear about what they're planning to do in the following year. And then in the afternoon, we had our Better Medway celebration event, and many of the award winners, because it is important to formally recognise the contribution that people make. Many of the award winners are listed in the Power of the Crowd report. So it is something that we can pat ourselves on the back for, I think, and be very proud of and formally give our thanks to the VCS and particularly to MVA for helping us build that capacity, Jane, and to all of the people who've joined as Healthy Walk leaders, who just take part in Healthy Walks, who come along to events and have shown tremendous commitment, actually, in terms of the champions to keeping that going and being advocates for some of the things that we want to achieve. So I'll go to Jane and then I'll come to you, Eddie.
Thank you very much, Councillor Murray. Can I just say, James, I'm really interested that you've mentioned social prescribing. Thank you for that. We do an awful lot of things in Medway incredibly well. And some of those things that we do incredibly well are held up as examples of national best practice. And I'm really proud of that. And I'm really proud that there's some involvement in a lot of these initiatives with the voluntary sector. This is really just a plea to encourage those initiatives to be not short-term funded, but longer-term funded, because we are aware of the fact that there are reviews being undertaken at the moment in terms of the funding issues associated with the initiative that we have in Medway, which is a cracking good initiative in social prescribing, which obviously opens up the offer for more beneficiaries, enables a sector capacity build, very, very necessary, and involves more and greater partnership work with people like the Health and Wellbeing Board and the Health and Care Partnership and indeed the ICB. So this is a long way of me saying, I think, could we have it logged somewhere that these initiatives actually need longer term funding, not short term funding? Because if you hand out a gesture to the voluntary sector and say, this is what we want to do with you in partnership, and then you withdraw that, it's very, very difficult for the voluntary sector to be able to maintain any sense of trust in those who are handing out that gesture in the first place.
A comment on that, and I'll just come to you, Eddie, please, as our last question.
Well, I actually just wanted to say how nice it was to see a report that's so uplifting. I must admit the title, Power of the Crowd, didn't click with me until I read it. And I got it, and obviously the can-do attitude of organising, fantastic. But I really want to comment on what James said about just talking to somebody. I do that as well. You know, I will look up when I walk around. I've got neighbours I say hello to. I still don't know where they live. And I'll say hello to people, and some of them look like you're some kind of weirdo. But that's how I want things to be, that we talk and we engage. And what I thought about your story was, I'm excited about what we're trying to do with regeneration. When we look at regeneration, we're talking about creating spaces. And as somebody who's lived abroad, obviously sunnier climate, what they have abroad is those outside places where people mix. We lack that here. And I think it's actually a very important element of the well-being, and especially when dealing with an issue I'm particularly interested in, and that is loneliness. And I just want to emphasize how I'm excited that we are factoring that in, and that, just talking to somebody on a bench, how important that is actually. That's all.
Thank you, Eddie. Have a good look at our design code for Chatham, very clearly designed in to that. Exactly as you say, it's quite right. James, please.
Thanks, Chairman, and thanks, members, for your comments. The challenge that we always have, and directly back to Jane, we were at the symposium, Jane, we understood and heard loud and clear the impact that the voluntary sector can have in relation to delivering better outcomes for our population. So it's your comments around resourcing is heard. Clearly there is a challenge, and the challenge from an NHS perspective, I can talk specifically about that, is that the resources are not finite. There are discussions that need to be had around that, but I hear what you're saying in relation to the need to provide some continuity for that kind of work, and that definitely is heard. And then just, I think David's got a quick update, Chair, on the data that was set out in the joint local health wellbeing strategy. But I just want to reaffirm, members, this annual report, and you can see the difference that we made last year, we made in terms of just focusing on those issues around hypertension. Just look at what we've been able to achieve. A number of the programmes that were initiated within Medway, as Jane's referenced, but had other ones that have been nationally shortlisted and finalists in a number of different categories. And I've got some more good news, which I won't share now because I know the board wants to get away about this year's awards. So really, thanks for the comments and the points that are noted. And next year's report will be quite interesting, I would suggest, but perhaps you want to just touch with David.
Okay, David, yes, please.
Thank you. Yes, just want to come back again to answer the question from Councillor Hackwell about the data item around, I can't remember exactly what it was now. Yes, common mental disorders. So that data item is based on a survey that takes place every 7 years. and the most recent survey looks like was in 2023, so just been completed. So I'm hoping we'll get the data sometime this year.
That's good news, thank you, and thank you for raising it, Councillor Hackwell. So Jane, I'll go to you, please, for this penultimate item.
Thank you. So just to ask the board to note the annual public health report, and I think with a specific action to review the long-term funding for initiatives.
Yeah, okay. Thank you very much. Last item today then, is that agreed? Sorry, we're all happy with that, are we? Yeah, okay. Flagging a bit now, yeah. Sorry about that. Okay, and so finally, item 11, the work programme.
I have nothing to add, but happy to take any questions.
I think that I don't know how other people feel, but I think we could probably add dentistry, actually, to our work programme. It's a national issue at the moment, but it is important. Yes, Victor? Sorry, Caroline, yep.
Were you going to add community pharmacy as well?
Yeah, well, but just being mindful that that is going to ask, so there will be the opportunity for a deep dive. But I think it's important. And I've certainly had a bit of lobbying, actually, from the pharmacy community about Pharmacy First. And so anything that you can feed to us for that, Caroline, I think would be very useful. Thank you. James is just saying there's a needs assessment being done across Kent and Medway about dentistry, and actually a really good push from public health that's been going on for practically the whole of last year and is still happening, as I saw at our excellent Welcome to Medway event. That is helping people maintain oral health and ignoring some of the noise about, well, you shouldn't have to tell parents to tell their kids to clean their teeth. Some families do need help with that, and some children do too. And I've seen some really good work at some of our community events, including the carnival, including all the stuff at Christmas, through Child Friendly Medway, giving away free toothbrushes and toothpaste and talking about the importance of oral health. We've got children going into hospital having their teeth extracted. That is not acceptable, actually. So thank you, James. I'm pleased to hear that. So thank you very much, everybody. Can we agree the work programme with those additions, please, Jane?
So to the committee to agree the proposed work programme with two additions, which is the dentistry and community pharmacy.
Great. Thank you for your forbearance in taking a bit longer, but I think it was worth it. There were some really interesting and good items. I wanted to do them justice. And we'll be a bit more careful with the agenda next time. Okay, thank you.